problems with the technology. So that's why we're a little bit late, but we'll try and get through the agenda in a timely fashion so that that we make up the time. And I am really delighted that today is the first time since the onset of COVID, the pandemic, that the board has been able to meet together in person for this meeting of the Trust Board. And for some of my IM colleagues in particular, who've been on the board for quite some time now, this is the first time we've actually been able to meet face to face. So that's really wonderful. The meeting today is being live streamed, and so for those of you joining our meeting remotely, you can be watching it live streamed today, or it'll be available on the Trust website shortly, should any member of the public or the staff wish to view at their convenience. And for those of you who've joined the meeting today, and I understand that's to be a mix of staff and the public, a very warm welcome to you all. Croeso cynnes iawn I chi gyd. So I'll begin the meeting first by taking apologies. And I have apologies from Jazz Abraham, our Exec Medical Director. Are there any other apologies that we wish to note? Thank you. In attendance this morning, I'd like to welcome some of our regular attendees. Stephen Allen, who I can see on screen, Chief Officer for the Community Health Council. I can't see if Brenda's here. Is Brenda here this morning?
No,
Stephen?
Chair. I just want no, Chair. I was trying to give her apologies, but I was still muted.
Okay, thank you, Stephen. Daniel Price should be here also from the Community Health Council. I think
No, Chair. No, Chair. No? He's not going to be on this meeting. He's actually attending the Cardiff Vale Health Board for me, so I can stay on this meeting a bit longer. Thank you, Chair.
Is David Cogan here? I haven't seen his name. So Katrina February, as usual, is the audit lead for Audit Wales, as one of our regulars. And I'd like to extend a warm welcome to Professor Peter Groves, who's already joined us, who's the Chair of Health Technology Wales. And he's going to join us shortly for the presentation of Health Technology Wales' annual report. Welcome, Peter. And a warm welcome to Mick Button, who's our consultant clinical oncologist, or one of our consultant clinical oncologists, who's deputising for Jazz Abraham. And we might, Mick is only able to stay with us for about 2 hours, a bit less now because of our late start. So I might move the agenda slightly to enable Mick to contribute to important items where we need Mick's input.
Thank you, Chair.
Have colleagues joining us virtually, as I said, as well as those around the table. So the procedure for asking questions, we need to, it could be tricky this morning, so please bear with us and we'll do our best. So if you wish to make a comment or an observation or ask a question, colleagues in the room, please raise your hands in the normal way. And Laura and I will try and keep a list of who's raised their hands and try and keep it in order. And colleagues virtually, if you can either wave or use your electronic hand. And again, Laura and I will do our very best to keep, to call you in the order in which you've raised your hands. That might not work absolutely 100% smoothly, for which I apologise in advance. But we will do our very best. So if I can take us now to item 1.3 on the agenda, which is declarations of interest. Is there anyone present who wishes to declare any interests which are pertinent to the items on today's agenda? No, thank you very much. So that takes us to item 1.41, which is the action log. Now we have 12 items on the action log, and I'm proposing to close 11 of those following satisfactory completion of the actions which are noted in the paper. There's one item which is open in relation to item 7.20, and that item is going to come to the May board. So I'm proposing that we close the first 11, and that final item will remain open until it's been to the board in May. Gareth.
Thank you, Chair. May I take you please to item 4, action 4.1, and at the top of the second page, where the action I don't think is quite correct in that it states that Claire James is going to inquire whether the audit report requires signature of the Auditor General. The point that was raised was that whether his name should appear on the report, because it refers to the first person singular. I have done this, I have done that throughout the report, but it didn't signify who the I was. I think we know it's the Auditor General, but nevertheless his name should appear somewhere in the report rather than the signature.
Thank you, Gareth. Thank you, Gareth, for that clarification. And I will turn to you, Steve, for a response to that.
Yes, so we'll take that away. If we leave it open for now, Chair.
So we leave that open then.
Mark
Yeah.
it as open. We'll take that away and we bring it back to the next meeting with that. Please.
Thank you, Gareth, for that clarification. Just reminding colleagues that if you have spoken with your mic on, please remember then to turn it off. So we now come, so we approve the action log subject to that modification which we've just noted. So we come to consent, and we've got 7 items for approval, and the remaining ones are for note. And at this stage, I ask if anybody wants to bring anything out of consent and discuss it in the main meeting. And so far, I have 2 items under 2.13, which Gareth Jones wishes to raise. Stephen Harris, you wish to raise something under 2.23. I wish to raise something under the gender pay gap report, which will be very brief. And then a 2.24 under the comms highlight report, I want to raise something very briefly. Matt?
Yeah, I just want to raise something under 2.1.4, the laundry.
2.1.4 under laundry. Well, I think Gareth wants to raise a point under laundry as well, so we'll take those together. It might be the same thing. So I'm not going to bounce around the agenda. Can we take those items now, please? So Gareth, if you could talk to the items under 2.13, which is under the commitment of expenditure exceeding the Chief Exec's limit. Thank you.
Thank you, Chair. The item that I wanted to refer to there was the extension of the contract of the MAC system. The covering paper refers to procurement advice having been received, and I think it would be helpful for the board prior to making a decision as to whether we extend that contract to see the procurement advice in order to ensure that we are complying with procurement regulations.
Thank you, Gareth. Is yours a similar point, Matt, or now Steve respond to that first?
No, mine was on the next item on the laundry. So.
Oh, so laundry.
Yeah,
sorry, Matt. Steve, you want to respond to Gareth's comment, please?
Yeah, what I was going to suggest, I think, Gareth, on that one is that we get that procurement advice, put it together, and we'll pull this out of here. We'll send it out then for Chair's urgent action, so you can be fully cited on the procurement advice that we've had.
Thank you.
And clearly, timescales we need to work within timescales we need.
Gareth, content with that?
Yes, no, that's fine. Thank you.
And then your next item, please.
The second point then was in relation to item 214, which is the transfer of the Llansamlet laundry asset. The engrossment, which appears at 2.1.4c, has the incorrect name of the trust in that it refers to Velindre NHS Trust, and it should be Velindre University NHS Trust. So I think we need to get that corrected, please, before the transfer is signed.
No, clearly it needs to change, so we'll take that away, Gareth, and make sure that happens.
Thank you. Thank you very much. Matt?
Yeah, that was exactly my point. I was just want to make sure the board were aware that we would get it corrected.
Thanks, both. Chair. Sorry. So, Stephen, you wanted to just point something out under 2.23.
Yes, thank you, Chair. It's the TCS Programme Scrutiny Committee highlight reports, and there are 4 of them this time. And just as an aside, in a sense, while we're on, what we've attempted to do is, there's been, perhaps in previous meetings, quite a delay between the highlight reports being produced and then coming to the board. So you might notice this time around, we've actually included the most recent highlight report, which was only actually from 10 days or so ago on the 22nd of March. So that meant the papers being uploaded a little late, but we felt it was beneficial to actually have the very most up-to-date reports included for the board. And it's just one point I want to highlight out of that most recent report, 2.2.3E on my IBAB system, which is the highlight report for the 22nd of March. And I just want to pick out one of the bullet points in Assure. So in terms of the TCS Transforming Cancer Services activity, as we know, it's a whole programme of activity made up of several closely interrelated projects. And we regularly review at this committee all of those projects, progress on them, challenges, etc., etc. And the board will be familiar with the good progress being made on several of these projects, the progress we're making on the new cancer centre, the progress on the radiotherapy, the LINAC replacements, and also the slightly slower than hoped for progress on our satellite centre. However, what the committee, the TCS committee, has been aware of for some time is that there's been no real progress on a couple of the other projects, in particular the development of our outreach services. And we can all understand the reasons for that, given the 2 years of pandemic, which of course have made it difficult even to provide the services we currently provide, let alone try and develop services in new locations closer to the population we serve. And indeed, on occasions, we've seen a slight reduction or withdrawal of some of our existing outreach services. For example, the service we have provided at Prince Charles Hospital, a service I visited recently with our Director of Nursing on the 15-step challenge, that we've seen a scaling back there of activity. But we now get to the point with the programme that we are becoming concerned that we need to be actually making some progress, good progress, quick progress on these other projects. And we did have a conversation about particularly outreach, and the fact of the matter is there are no real timetables for taking that forward, and there's no real identification and resourcing. So as a result of that, we've added it as a new risk into the programme risk register. So that's the bullet point, the first bullet point in the paper under Assure. The new programme risk has been added as a risk 20. Some of the IMs, including myself, have met with the Chief Exec and the senior team just to expand on this, to express our concerns. I think there's a follow-up meeting planned. But obviously, we need some papers to be produced on this. But more importantly, of course, we need some action and activity because, as I say, I'll conclude where I started. These projects are all interrelated. And it's essential we start making good progress on the projects we've been unable to make progress in over the past 2 years. So I'll stop at that point. I don't know if any of my colleague IMs from TCS Scrutiny want to add to that. But I say this is primarily for information as part of our assurance role.
Thank you for that update / clarification, and I confirm that resembles almost exactly the discussion that took place in the scrutiny committee, and thank you for drawing it to the board's attention. With a bit more time, scrutiny committee butts up against which is once a month. It butts up against normally have included that oh, I can't, Carl, if you've got your hand up, I can't see you at all. Just letting you know that.
Yeah.
Carl.
Thanks. Yeah, no, thanks, Stephen. As you rightly say, we've had a good number of conversations about this project, and I guess just subsequent to those discussions, just a couple of things to make the board aware of. First of all, as you're well aware, we were doing a programme stock take anyway, Steve, so that work has come to conclusion, which does almost understand where we are now. The second part, Kath, and Nick have agreed. So Kath is off and we're off doing just rescoping that, because as you say, a lot's changed over the past 2 years in terms of both COVID, but also how the system is starting to take forward their own particular plans. So that piece of work is in train. And the last piece is understanding the resource requirements. We've got that, and I think it's about applying the resource. So as just to give you assurance that, as you described, Stephen, we're fully aware of the risks, and Nicole wants to speak now. The other thing I did say before, I guess giving some assurance that, if you recall, essentially we've got a first step is to go back to where we were in terms of outreach, and the second is to go a bit further, but we do still have 3.5 years to get there. So whilst that's not intended to be any comfort at all, but it just gives you a sense that we still have sufficient time in our view to do what needs to be done. So, but Nick wants to add.
So thanks, Carl. I got two people. I'm not sure who was first, Mick and Nicola. So can I take you first, Nicola?
Thank you, Chair. I just wanted to add a little bit more context. So it's about a year since the work on outreach was paused, but prior to that, we had done significant work with all of our health board partners. We'd agreed the principles for which outreach would be working, leading into the new build, and significant work had happened. So it's a year since we paused it. Some of that was due to capacity issues across the health sector given the COVID, but we are now working through the resources to re-energise that work and get that happening. There is particular work in one health board that is progressing really well, and that's with Naira and Bevan. So I didn't want the board to think that we've not been progressing that work, and there has been quite a lot done. It's just picking that back up, and you're quite right, Steve. We now need to address the resource issues. Thank you.
That's very helpful assurance, Nick. Thanks very much. Mick?
Thank you, Chair. I just wanted to come in maybe from a clinical perspective, and recognising the difficulties the whole of the NHS has been through over the last 2 years and the very understandable changes that we've had to go through. But to emphasise the importance of this piece of work, it's good to hear that it's recognised and there's work happening at the moment, and that will increase in the future. I think as a regional cancer centre, it's really, really critical for us to be local to our patients where we can, maintaining that high quality, safe, resilient care across the region of South East Wales as best we can. So it's good to see this being developed more, and looking forward to supporting that from a clinical perspective.
Thank you, Mick. Please be assured that we are taking it very seriously, and as far as the IMs are concerned, we're raising it now at every scrutiny meeting, and Stephen will preside over that, and we will feed back to both scrutiny and to this board. Hilary, I can see your hand is up.
Yeah, I just wanted to just support what Stephen had said, really, that he'd summarise the views of the IM members on the subcommittee very succinctly. But I'm also glad to hear from colleagues that things are going to be progressed, and as Stephen said, we have got another meeting in the next week or so to discuss this further, so thank you.
Thanks, Hilary. Can't see any other hands up, so I wanted to raise 2.17, the gender pay gap. Oh, somebody's hand just gone up.
Yes, it was mine, Chair.
Stephen Allen, sorry, Stephen. It's a yellow hand on a white logo, so
which doesn't help. I know. I do apologise for that one. It's linked to the TCS issue, if that's okay, on the engagement paper that you've got. Whether it's appropriate to raise that now, Chair, please let me know if it's not. Just a bit concerned, really, that there seems to be a lack of engagement with the CHC and my CHC colleagues across Wales on the TCS programme engagement, despite the fact there's a really detailed report here. I just wanted to sort of flag that up as a concern that the CHCs have. is that we seem to be missed out of your ongoing communication on TCS. Since it affects a number of our CHC areas, I think it's really important that the comms team actually engage with us in a much more concise way and a much more frequent way than they are at the moment.
I don't know, Carl or Kath, do you want to respond to that?
Yeah, no, thanks, Stephen. So first of all, apologies if we haven't done that sufficiently. So it's really important that we raise that. And I guess outside of this meeting, perhaps an action would be to come and for us to understand how we can do that better in a way which suits you guys. We've had really good engagement throughout the process. We want to build on that, not lose it. So if you're happy to do that, Stephen, I can pick up outside myself, Kath and Laura, and just so what works best for you, really, because it's really important we continue to do that good work. So if you're happy with that, Stephen,
yeah, thank you.
Sort the next couple of weeks.
Yeah, that's brilliant. Thank you.
Laura, do you want to respond to that?
Just to completely agree, thanks, Carl. And we'll appreciate we have some different types of communication with you and your team, Stephen. So we just need to, I guess, not just address the immediate now, but make sure that everyone's comfortable with what that system and rhythm of us working together is going forwards, and set that up and stick to that. So thank you for raising it. Thank you.
Thanks, Stephen. Thanks very much. No hands up anywhere. I still can't see you, Carl. So. Oh, Matt, sorry, I didn't.
Sorry, it wasn't anything to do with TCS. I didn't know there was another paper in consent. You know, the charitable funds update.
Yeah,
all right. Sorry.
Yeah, it's on my list.
Sorry.
I'm going to get.
Sorry, Chair.
And I'm going to get to it. So the next item I wanted to raise was 2.17, which is the gender pay gap annual report, which is here for approval. And I would recommend that we do approve this report. It's a factual report, which sets out the current position. And I've had a discussion with our head of workforce and OD, Sarah, to say, look, but it does raise some issues, which is acknowledged in the report. And I've spoken with Sarah to say, I think it would be helpful if we as a board looked at those issues together, and perhaps we could pick that up in a board development session very soon, Sarah, to take some of the actions that are listed in the report forward.
Yeah, thank you, Chair. And we've already got work underway to take account of the analysis we can now do on the 21-22 data. So we can actually build on the items listed in the report. As we know, NHS left us at the end of 2021, which is the period covered by this report. That will significantly alter our findings, but also we know that we need to get underneath the level that we report here. So we are already planning to do that work, and we bring it back to a board development session. So
that was the point I wanted to raise there. Can't see any hands up. I also wanted to raise an issue under 2.24, Transforming Cancer Services Communication Engagement Update, which Lauren would normally speak to, but I just wanted to know if you would update us on the Petitions Committee, Lauren.
Thank you, Chair. So since the report was written and published, the Committee for Petitions at the Senedd heard there were two petitions, as colleagues will recall or have read about, one in support and one in against the building of the New Cancer Centre on its proposed site. And the matter hadn't been closed formally by the Petitions Committee in the previous Senedd session. So it was brought back to a meeting earlier this month, and the recommendation from the chair of the committee was to close the matter. He didn't invite any debate from members of the committee on it, and asked if anyone wanted to comment. No one did, so the matter has been formally closed with that committee now.
Thank you, Lauren. I thought it was important that we had noted that update at board. And then I think finally under 2.25, under the Charitable Funds Committee highlight report, I'm not going to speak to the report. I just want, unless anybody's got a query or an observation, but I just wanted to add one matter which will in due course be reported fully to the Charitable Funds Committee. I don't know if you want to read this out, Matt, as our Director of Finance, which is about, we've looked to see if our charity had any investments in Russian companies in light of what's happening in Ukraine. And we've had a good look at that. And Matt, do you want to just update the board?
Yes, thanks, Chair. So we had a number of discussions with our investment advisors, Bruin Dolphin, and they did come back and confirm that there were no direct exposure to Russian securities. We then had follow-up queries from Stephen Harries around, well, what about indirect exposure through the fact that the fund invests in portfolios of securities. So they did further review of those funds, and there was some exposure there, a very small amount. And then we instructed them to sell, I think, those funds, which they have done, at no transaction cost. And so as far as they're concerned now, our exposure in terms of any Russian companies is zero.
Thanks, Matt. We will report this in full to the Charitable Funds Committee and through the Investment Subcommittee as their meetings come on stream. But I thought the board would welcome knowing that. Andrew?
Just as a follow-up, tobacco companies, is there exposure there? Do we know that? Is that a part of a policy? I'm just sort of interested in sort of ethical investment strategy.
I mean, there's a range of ethical considerations that are actually set out in the investment policy for the charitable funds, and tobacco is one of them, arms and military, etc., etc. So we can share that with yourself if you want to have a look at the ethical policy section.
Thanks, Matt.
And Martin chairs our investment subcommittee. If you wanted to talk that through with Martin at some point, Andrew, I'm sure that'd be fine, Martin. So I don't have any other issues. I just wanted to note under 2.2.1, the policies approved report. Just to note, that's a very long report, and just to note, the policy for policies, which is our framework for how we agree policies, has been to ENB, that's the executive board, and approved. And then there are 4 individual policies which were approved at the Quality, Safety and Performance Committee last week. Just to make that clear. And so that completes, oh, sorry, Andrew, Gareth.
Sorry, Chair, but apologies for taking us right back to the start of consent items and the minutes of the last meeting. There are just a couple of points on those, one of which I've already mentioned about the audit report and requiring signature of the Auditor General, which is incorrect. And the second point relates to item 7, I think, if I can get to it, 7.2, the discussion and presentation we had on the Cancer Research Hub. There are a number of, there's a summary of the discussions and the comments, which is set out in bullet point 4, which is on page 15 of the minutes. I think it'd be helpful going forward just to note that a number of those points were raised by independent members. And secondly, that I know that you and I both raised a particular point regarding intellectual property rights, which doesn't appear in that bullet point summary of the discussions. I appreciate taking minutes they're meant to be a summary of the discussion, but nevertheless, the intellectual property rights point was an important one, which I think should be reflected.
Thank you, Gareth. That's a very important point, which we are pursuing, the intellectual property rights and discussing at research subcommittee and so on. Is everybody content we make those alterations to the minutes?
Absolutely, and just to provide assurance in terms of the development of the heads of terms principles is absolutely part of that. So
it needs to be in there.
In terms of the content and the work, it's absolutely there. So we'll make sure that's clearly reflected in the minutes.
So are there any other items? We've had a long consent agenda, but we have raised, it's been important that we've discussed the issues that we've discussed. Are there any other items in consent? If not, I'm going to move on to the next item on the agenda, which is item 3, which is the presentation of the Health Technology Wales annual report. As you know, Health Technology Wales is a hosted body. Velindre University NHS Trust hosts Health Technology Wales, and I meet fairly regularly with its chair, Professor Peter Groves, and our chief exec is a member of their board. And we're going to, Peter, you have a presentation for us. We've had apologies from Sue for today, who's not able to be with us, but you're very welcome, Peter. And I'm going to ask Julie if she can share your presentation, and then I'll hand over to you. Yeah. So there's the presentation is on screen, Peter. So I'll hand over to you.
Chair, thank you very much indeed, and thank you for that kind welcome and for giving me the opportunity to present to the board on behalf of colleagues at Health Technology Wales. And my report is going to cover the calendar year for 2021. I know that some colleagues will be familiar with our organisation. We've spoken to the board before, but some may not be. And certainly some people watching this presentation distantly may not be as well. So I'm going to begin by giving a brief introduction and reminder about Health Technology Wales, who we are, what we do. And then I'm going to go on to specifically refer to some of our outputs and achievements during 2021. And then finally finish with some reflections about our aims and objectives for the coming year. So next slide, please. So Health Technology Wales is an organisation that's been in existence since 2017 and resulted from the Welsh Government 2014 Access to Medical Technologies in Wales report published by Welsh Government. So that report concluded the need for an all-Wales medical technology appraisal mechanism that comprised a more strategic approach to the commissioning of new medical technologies in Wales that was driven by clinical and population need, was evidence-based, ensured equity of access for patients, and involved wide engagement with clinicians, with patients, with industry and research partners. And our remit also was extended to include the promotion of adoption, not just of Health Technology Wales guidance within the system, but also guidance coming from our partner organisation, NICE, as well as to oversee, importantly, a process to audit the system response to guidance. Next slide, please. So just to remind everybody, Health Technology Wales is funded by Welsh Government. We're delighted that the governance is overseen by yourselves at Velindre University NHS Trust. We actually have a physical presence down in the Life Sciences Hub Wales in Cardiff Bay, but for understandable reasons, during the last 2 years, most of our work has been done virtually. Next slide, please. The vision of our organisation is to develop a world-class health technology assessment organisation that facilitates the identification, the appraisal, and the adoption of Health Technology Wales that offer most promise to deliver improved health outcomes and value for the people of Wales. Our mission is to drive improvements in population health and care services by applying the best available evidence to inform decisions on the appropriate use of health technologies in Wales. Next slide, please. There are some very important principles on which we base our work. And the first is surrounding evidence. Everything that we do is evidence-based. Our decision-making meetings are held in public. All of the evidence that is considered by our decision-making meetings is published subsequently on our HTW website. Our processes are transparent and rigorous. Our work involves collaboration. We work very closely with experts, with members of the public, with patients, and although we work closely with them, ultimately we are independent from both them and from Welsh Government. And all of our work is informed by stakeholders from the wider health and social care environment. Next slide, please. Our Health Technology Wales team is led by Dr. Susan Miles, who is director. During the last year, we were delighted to receive an uplift in our financial support from Welsh Government to just over 1.5 million. And we also had additional funds through our involvement and recruitment as a collaborating partner in the Wales COVID-19 Evidence Centre. And I'll talk a little bit more about that later on, but that allowed additional funds of just over £140,000. But to support that increased work, we were able to recruit some new members of staff, and Susan Miles has done a wonderful job in gathering together a group of highly intelligent, highly motivated and dedicated individuals who comprise health service researchers, health economists, information scientists, communicators, project managers, and administrators. And we have three fundamental core functions. The first is, it's important that we identify technologies that have the promise and the potential to have benefit to patients and also to the healthcare system. We then undertake formal health technology assessment appraisals based on published evidence that support either benefits to patients or benefits to the healthcare system. And where necessary, our health economists undertake additional economic modelling to support that process. And we publish then our guidance on the HTW website. And finally, I've already alluded to the importance of our organisation in then promoting the adoption of guidance by the health and social care system and overseeing an audit process of that adoption. Now, to support the work we do, we have two independent professional advisory committees. Our assessment group comprises 11 multidisciplinary members. The responsibility of this group, which is chaired by Susan Miles, is to oversee topic selection, but also to oversee the scientific rigor of the evidence that's gathered together and formulates the evidence assessment reports that are then passed on to the decision-making group, which is the appraisal panel, which I chair, which comprises 26 multidisciplinary members from representation across the whole of the health and social care sectors in Wales. And it's the job of the appraisal panel to consider all of the evidence put in front of the panel, including not just written evidence, but also advice from experts, advice from patient experts. And then we reach guidance recommendations on specific topics that are published on our website. So next slide, please. So with that introduction, I'd like to now turn to the HTW audit report for 2021. And just to be clear, this report comprises data from the calendar year 2021. It's our intention from this year onwards to actually switch to reporting activity over a full financial year. And we'll do that from next year's report subsequently. So the three sections of our report comprise, firstly, reporting our outputs and activity in regard to our core functions surrounding health technology assessment. The second section involves reporting our engagement with key partners and key stakeholders within the system. And finally, very importantly at the moment, the third section, the work we're doing to support Welsh Government in its response to the COVID-19 pandemic. And my intention in the next few slides is to step through each of these three important elements to our report. Next slide, please. So firstly, in regard to our health technology assessment work, during the course of 2021, we received a total of 88 topics that were referred to us for consideration. And of these, just over half of them, 49, were considered to be within our remit and therefore worthy of further exploration. And the Health Technology Wales researchers then comprised relatively high-level summaries of the evidence surrounding each of these technologies in regards to the potential patient and system benefits. And we refer to those high-level reports as topic exploration reports. And these then formed the basis of our selection process. Two elements to that. Firstly, each technology, each topic is then scored against an agreed scoring system. And then the topics are discussed by the HTW assessment group. And as a result of that selection process, selected topics then progress towards appraisal. At this point, the HTW team put together a much more detailed summary of the evidence. And for 2021, 12 topics were selected for that process, and 9 evidence appraisal reports were generated. So out of the total topics notified to us, approximately 1 in 7 of those progressed to evidence appraisal, which resulted in 2021 in the publication of 6 pieces of HTW guidance published on our website. So next slide, please. Let's stand back a moment and see how that fits in with the perspective of all of the work we've done for the last 4 years, so since 2017. So during that period of time, we've seen more than 300 topics now notified to us. And it's interesting to note that most of those have come from the National Health Service, perhaps not surprisingly, but also from industry. But we've had topic notifications from government, from the third sector, and also from academia as well. And as you'll see on the right-hand part of the slide, of that group of topics notified to us, just over half of those have resulted in the sharing preparation of topic exploration reports. And the output of Health Technology Wales now comprises a total of 23 pieces of national guidance that have been shared with the health and care systems. Next slide, please. So this slide just summarizes the Health Technology Wales guidance published in 2021. Starting from the top, HTW supported the implementation of a new innovative treatment called corneal cross-linking to treat both children and adults with an eye condition called keratoconus, which is a condition that, if not treated, can lead to progressive blindness. We were delighted that we were able for the first time to publish guidance on a social care topic. So Strategies for Relatives, or START, is a program that supports carers of patients with dementia in the community. I know as a cardiologist that patients presenting to the emergency department with breathlessness, it's very important to identify those that have heart failure as distinct from other potential causes. And in 2021, we published formal research-based guidance on the use of novel biochemical testing to be able to support professionals to either rule in or to rule out a diagnosis of heart failure. We published guidance on a very interesting digital technology called Freestyle Libre. We know that diabetes is a very common problem within Wales, a very high source of morbidity and mortality. And monitoring of blood glucose is very important. Conventional methods of doing this is a pinprick test, which is potentially painful, but also very inconvenient to patients. So Freestyle Libre is a digital technology that is placed on the outer aspect of the upper arm and measures constantly interstitial blood glucose. So just by scanning across it with a mobile telephone with an appropriate app, gives the patient or a carer a continuous measurement of blood glucose, and then the dose of insulin can be refined accordingly. So our guidance supported the evidence, suggesting this was not just clinically effective, but also cost effective. We looked at the evidence for the use of point-of-care ultrasound to diagnose gallstone disease. Patients presenting with abdominal pain concluded there's need for more research in this area, but this is a very promising technology that we would encourage more studies to be done on. But finally, we promoted the adoption of an antimicrobial barrier cap for placement on the end of hemodialysis catheters for patients with end-stage renal failure, where we saw that the evidence pointed to a reduction in line-associated infections and a very cost-effective use of this new technology. Next slide, please. But our work at Health Technology Wales doesn't just finish with appraisal. It's very important, as I've already alluded to, that we support the system in adopting our guidance. And this area of work is overseen for us. We're very grateful by the All Wales Medical Directors Group, both individually within their own organisations, but also collectively as a group. And during the last year, each of our local health board medical directors has ensured that within their organisation, we have a lead person nominated to liaise with Health Technology Wales. And this person oversees and chairs a local committee, which is responsible for ensuring the implementation, the adoption, but also overseeing an audit of that adoption process for that organization. This, I must emphasize, is not just for HTW guidance, but medical technology guidance coming out from NICE as well. Now, to support this, we've agreed collectively audit methods with our partners. We've established a pilot, which is now completed, of the uptake of 8 pieces of carefully selected HTW guidance. And we're now in the process of collating the data, putting that information together into a formal audit report, which will be submitted to Welsh Government in the next few weeks. Next slide, please. This slide just summarizes the names of the individuals in each of the health boards, the local health boards, who has taken a lead role in liaising with Health Technology Wales and also the committee that they chair. And I just wanted to take this opportunity to thank them for the hard work and also the leadership they give to this valuable work for us. Next slide, please. It's important not just to look at the tangible outputs, but also think about the potential impact of our outputs on patient care and the healthcare system and the social care system in Wales. And our HTW researchers have estimated that if all of the guidance that we've now published were fully implemented across Wales, there would be more than 188,000 patients per year who would benefit from implementation of our guidance. We're very excited and pleased in 2021 to receive an international and prestigious award as an organization. So the International Network of Agencies of Health Technology Assessment is an organization that brings together 49 international HTA bodies. And at their annual meeting in 2021, we were awarded the David Haley Prize for the Best Impact Story. So this followed presentation by our senior researchers of the work that we've done around the use of stem cell transplantation for managing relapsing, remitting multiple sclerosis, and the impact potentially of implementation of that guidance and the lessons learned from the project were considered to be worthy enough to receive acknowledgement and award of this international prize from our peers. Next slide, please. So I've already touched on the fact that within HTW, we consider engagement with stakeholders and collaborators as being fundamental to the work we do. Very importantly, in 2021, we established a stakeholder forum, which comprises very senior representatives from across the health and social care sectors. This group is chaired by Sarah McCarthy, who is Director of Improvement and Development at Social Care Wales. And 2 meetings were held during 2021. And 2 meetings per year in subsequent years will now take place. And the importance of this group is that it connects us in a sense with our constituents and makes sure that the work of HTW reflects the priorities and strategic important issues that are relevant not just to healthcare, but also to social care. We've also strengthened our partnership with Social Care Wales during the last year. In 2021, we held joint roundtable and workshop events with them, and this led to us better understanding the needs of our social care sector and also the ways in which HTW can better support them in our work. And finally, it culminated in the launch for the first time of our social care open topic call in February this year, and we're just in the process of now looking at all the topics that have been referred to us, collating the evidence and deciding which to proceed with for formal health technology assessment. We've also done some very important international collaborative work, which has led to the production of position statements in the role of patients in undertaking health technology assessment, and also the potential for disruptive technologies to impact significantly on healthcare delivery. We've had meetings throughout the year of our assessment group and our appraisal panel, despite the pressures of COVID-19. We've held executive group meetings, industry user group meetings, and patient and public involvement standing group meetings, and I'll come back to this work in a moment. We've either hosted or co-hosted 10 events, including virtual webinars and workshops, and our website and social media presence has been as busy as ever. Next slide, please. So the involvement of patients and members of the public in the work of Health Technology Wales is fundamental to every step of what we do. And our PPI standing group has adopted a multifaceted but then a targeted approach to the way we do this. And during the course of 2021, we've had specific evidence reviews, we've had questionnaires circulated and returned to us, and we've had individual patient opinions. So we've had a wide diversity of inputs that have helped us understand patient and public perspective in regard to specific topics. And the work of our PPI standing group is now already receiving international acknowledgement. Next slide, please. Side by side with our core health technology assessment work, we've continued to contribute to the Welsh Government response to the COVID-19 pandemic. During the course of 2021, HTW became a collaborating partner in the Wales COVID-19 Evidence Centre. We collaborated with colleagues in Europe in publishing externally published reports. And throughout the pandemic, HTW researchers have maintained an evidence digest of published studies relevant to COVID-19, accessible to professional and members of the public colleagues. Throughout the pandemic, we've offered a free scientific advice service to technology developers, both for therapeutics and diagnostics relating to COVID-19. Next slide, please. Next slide, please, thank you. The Wales COVID-19 Evidence Centre is funded and established by Welsh Government through Health and Care Research Wales. It's hosted by Cardiff University under the directorship of Professor Adrian Edwards. And we were delighted to be appointed as one of 6 collaborating partners in this centre. The intention of the centre is to ensure that up-to-date evidence is made available to Welsh Government and also to the decision-making groups within Welsh Government responsible for both public health and also social care policy generation in response to the pandemic. So the important work we do contributes to that process. Next slide, please. So the contributions made by HTW to the Evidence Centre include the provision of research and analytical expertise. We've published during 2021 rapid evidence reviews, including the risk of transmission in vaccinated populations, the potential impact of face coverings to reduce transmission, the potential use of convalescent plasma therapy for COVID-19. And we've also published evidence summaries looking, for example, at the effectiveness of home oxygen monitoring with oximetry in patients with COVID-19 and the transmission in public areas and semi-covered settings. We've also updated a report that we published in the very early days of the COVID pandemic, looking at the effectiveness of different testing strategies for COVID-19. And throughout this period, therefore, we've been able to continue to support Welsh Government in each of their decision-making groups. Next slide, please. So I've presented to you a lot of data and information about what we've done in 2021. I'd like to just summarize now against 5 objectives we set ourselves at the beginning of 2021 as being the important ones for our year. So firstly, our intention was to expand HTW's topic identification, prioritization and selection work. To do that, we've increased our open topic call from 1 to 2 per year. As I've reported to you, we received 88 topic referrals as a result of that and other notifications. And we've refined the HTW topic selection and prioritization process. Our second objective was to significantly increase our evidence appraisals and guidance output. And I think we need to consider the combination of our core HTA guidance, but also our COVID-19 evidence publications. We produced 49 topic exploration reports, 9 evidence appraisals, and I've reported to you 6 pieces of national guidance that were published during 2021. Our third objective was to target very specifically social care and digital care innovations. And we've done this by establishing a collaborative partnership with Social Care Wales. We've held our first HTW Social Care open topic call, and we set up an expert advisory group, a task and finish group, specifically to advise us on implementation of the digital open topic call, which I'll touch on a little bit later. Next slide, please. Our fourth priority was to continue to support time-critical COVID-19 care and decision-making, and we've done this by becoming a collaborating partner in the Wales COVID-19 Evidence Centre. As I've reported to you, we've produced evidence reviews and summaries, and we've supported key Welsh Government decision-making groups. And our final objective was to establish and pilot the HTW technology audit of implementation and adoption of R and NICE guidance. In doing so, we've co-produced the audit methodology, we've piloted the first audit during the course of 2021, and we're now in the process of preparing our first formal audit report, which will shortly be submitted to Welsh Government. Next slide, please. So we're very much now concentrating on the now and the future and planning our year ahead. In doing so, we're touching reference to the HTW strategic plan that we published last year, and indeed myself and Susan presented to the board, which identified, I'll remind you, the immediate, the medium term, and also the long-term strategic objectives for our organisation. I'll remind you also that this was developed in consultation with stakeholders, including Welsh Government, opinion leaders, representatives from Welsh health and social care systems, as well as from representatives within our decision-making groups at HTW. And this was signed off and agreed by the Minister for Health and Social Services, Eluned Morgan, and is now very much established as part of our planning vehicle. So the plan was created as a living document with the intention to revisit and update where appropriate, so that it reflected the prevalent social care and healthcare circumstances. Next slide, please. And this is my final slide. I wanted to share with you our conclusions and objectives for how we should work during this and the coming year. And to inform this, myself, Susan, and our senior team leaders met in January to go back to our strategic plan and to draw conclusions as to where we should focus our attention. So stepping through this briefly, in terms of identification, we see the expansion of the HTW topic identification process as an ongoing process. But specifically this year, we'd like to focus on developing and promoting direct topic referrals from our partners in local health boards, local authorities, Social Care Wales, Digital Health and Care Wales, and the specialist health boards. We're going to focus particularly this year on a digital topic call, which will take place in July. And we have the Task and Finish group, which is currently working. We hope the conclusions of their work and their professional advice will be available at that time to guide us as to how we should respond then to the topics that have been notified to us. In regard to appraisal, an ongoing process is to significantly increase our appraisal and guidance output, and to facilitate that this year, we're moving to holding monthly meetings of the appraisal panel. I've alluded to the fact that we intend to target digital innovations for appraisal as well as social care innovations for appraisal as a result of the social care topic call that we've completed. We're going to continue to support time-critical COVID-19 care and policy decision-making. And this year, we also intend to publish our appraisal methods and processes to ensure that they comply with the best international practice. In regard to adoption, we are preparing our annual audit report already, and that's now going to become a rolling process that's established in our methodology each year. Because of the social care focus this year, we're going to learn from the healthcare pilot of adoption audit to try and see how that might be applied to the social care setting. We acknowledge that the social care setting is a lot more complex. So we're going to begin the process of designing an audit process for uptake of social care guidance that will come from our organisation. And we also want to further develop the scientific advice service that we offer to support the Wales life sciences and innovation landscapes. In regard to engagement, we want to further develop our collaborations both within the UK, and we are developing very close working relationships with NICE and our Scottish Health Technology Group colleagues. But we also want to expand our collaborations further with our European and international partners as well. And our intention is to update our communication strategy so that we can optimize our engagement with stakeholders. So next slide, please. So Chair, thank you again for giving me the opportunity to report for colleagues on behalf of Health Technology Wales to you today. I want to finish by acknowledging and applauding the work of Susan Miles and her fabulous team, the hard work they've put into the last year and the achievements that have come from that. And I'm going to finish there, but I'd be very happy to take any questions or comments that any colleagues might have. Thank you very much indeed, Joe.
Thank you, Peter. That's a very detailed, comprehensive, informative, interesting report. Before I open it up, I'm going to, as a fair warning, I have one question, one suggestion and one observation that I want to make. I can't see any hands up, so I'll ask my question. Oh, there's loads of hands up now. Nick.
Thank you. I would echo the comments the Chair's just made. I have one question, and that's relates to slide 12, where you describe the links you have with the 7 health boards. And I noted the absence of trusts and Velindre in that, as well as public health and WASP. So I'm guessing it was a summary slide, Peter, and you do have those engagement links with trusts, including Velindre?
Yes, we do indeed. Yes, please be reassured about that. So just for clarification, that slide was summarising the representatives and their committees in the local health boards who are part of the pilot audit that will form our report this year. So I must emphasise the word pilot because we obviously had to start relatively small, and we intend to build big in terms of the audit of our implementation of our guidance. So just for clarification, we're starting by auditing the uptake of our guidance within the local health boards, but our intention in future years is to extend that to include specialist health boards like yourself, WASP and other organisations, importantly too. That slide was not a summary of all of our collaborations and partnerships that we hold within the system for other work. And please rest assured that we've got very strong collaborations with, of course, Velindre, not just from an executive point of view, but we've got strong connections with Dr. Jacinta Abraham, your medical director, and Robin Davis, your head of innovation as well. And indeed, we've strong representation with Dr. Tom Crosby on our appraisal panel as well. So established links with Velindre are strong already, and their exclusion from that slide didn't in any way mean to exclude them from importance as collaborating partners.
Thank you for confirming.
Thanks, Peter. That covers my observation, because the observation I was going to make was to welcome the increased collaboration that there's been with Velindre over the last year, particularly with committee membership, the grand round, and so on that you did, and the close working that's being developed with Jazz. And I was just going to make that observation. So that covers that one. I've still got 2 points. Matt, did you have your hand up? Right. I got Carl and Andrew. And then I'll come in with my, and Steve. Carl first.
Peter, thank you very much. That was really helpful. These are more comments than questions, but I was pleased to see at the end the increased engagement with other UK and international partners. I think there's a tremendous amount you can learn from each other and actually avoid potential duplication of effort, because these are health technology benefits for patients wherever they are, right? Other just specific patients in Wales. But that was great. So I absolutely support that. The other aspect was just around this adoption and implementation into practice. We know how difficult this can be within the NHS. So I just wanted, again, reassurance. I know you're doing audits around this, but where your reports land, where they're published, how they're enforced, do they come with some kind of, I guess, the Welsh Government recommendations? Are things mandated? How do we, that really difficult task of changing practice for the benefit of patients within healthcare systems? Interested in the comments,
Of course, and I think that's a very important point. So the formal Welsh Government approach is that Health Technology Wales guidance should be adopted, and if not, there should be a justification given why the guidance has not been adopted. So it's adopt or justify. So that is the responsibility, in a sense, in terms of the system response. We would like to go further than that, and we are in negotiation with Welsh Government as to how that might be achieved. We would be eager for incentivisation of the system to promote adoption in a slightly more proactive way. But nonetheless, the adopt or justify is a firm position that's been taken by Welsh Government, which shows the support they give and the validity they give to the work of HTW. But I think different approaches are being considered as part of the Welsh Government innovation strategy that is currently under consideration. I think that's an important element of their work at the moment, to see whether there can be a stronger support to the implementation of our guidance. I think that the first point that you made about international collaboration and national collaboration is a really important one. We place a large emphasis on this area of work, and just to be clear, the work of HTW very specifically does not duplicate the work of NICE, and we have a memorandum of understanding with both they and our Scottish partners to ensure that we all know of each other's work and have a working relationship, so that our programs are shared and that we don't take on projects that we know other organizations are doing. And of course, when the guidance comes out, we actually share that very much within the group of HTA organizations. And our aspiration actually is to join up our working between organizations, so that we can actually have joint projects as well. As you rightly say, the outcomes are very relevant to patients wherever they live, and the therefore kind of possibility of joint collaborative projects is an important one for the future for us.
Thank you.
Thanks. Thank you, Peter. The other observation I was going to make fits in with this, your question, Andrew, which was 188,680 patients would benefit. That adoption report is going to be really important to the system when it comes out, and well, I really look forward to receiving that. Carl?
Yeah, thanks, thanks, Peter. Yeah, I just echo everybody's thoughts. It's fantastic work. Just a couple of your thoughts really on, I guess, we've got a scarce resource in terms of the NHS, and you've got a scarce resource in this expertise. So my sort of question, your thoughts from yourselves about how strategic alignment. So how do we align the strategic appraisal process with some of perhaps the key strategic policy intentions and drivers? And you did mention as an example, sort of digital. So appraising digital of itself is of some help, but appraising digital is a key enabler of system change. So it's just how your sort of observation about how we get best alignment, but then I guess also the other end of the spectrum, leaving enough room for, I guess, pioneers and innovative practice as well. So that's my sort of first question. And can I just be cheeky and tag on a second bit then? So again, I spoke to Susan a while ago then about if we take that as the potential alignment, and then around almost an appraisal of strategic system change, sort of longitudinal study. So, you know, we're trying to shift the cancer system in South East Wales. So is there something we could do? And I'll give you an example, I don't know, using wearables as a prevention and self-management. So there's a bit in there, but just first of all, alignment. And second of all, would you or could you be interested in a long-term, longitudinal study of a system change?
Could I just ask Peter for a fairly succinct answer, because yes, time is moving on.
Okay, I'll try. Those are really big questions, so it's a challenge to get.
Exactly.
Yeah. So I think the first. No, that's okay. The answer to the first is all about engagement, and this is why we have such strong collaboration with stakeholders, right at the top of the systems and all the way down to ground level as well. So in answer to your first questions about strategic priorities, we recently held a meeting, for example, with Judith Paget to talk about how we could align best with her intentions and plans for NHS Wales. We've got this really strong collaboration now with Social Care Wales and with Public Health Wales. So having really strong connections with people right at the top, in a sense, of the strategic planning is fundamental to making sure that we provide the support we need to as an organisation to them, but staying open to our constituents is really important, which is why we have the open topic call, which means that for whether it's digital, social care, general topics, anybody can report topics to us. So we've got those connections with people who use the services. In terms of the kind of plans for longitudinal studies, we're always interested to talk with colleagues about how we can support in that process. Our scientific advisory service is really fundamentally around our ability to provide advice around evidence generation. But the work of HTW, I'll just go back to the beginning, is fundamentally based around evidence. And unless evidence exists, it's very difficult for us to become involved at that early stage. But we are very proactive about wanting to be there to advise and to inform how others, including the system, can go about change and then generating, importantly, evidence to support that change at the same time prospectively.
Thanks, Peter. Steve, you wanted to come in? And
Yes.
then I'm going to wind this item up.
Okay, thank you, Chair. I mean, mine's a comment around the question, Peter. You and I have long discussions in various settings. I think you've captured in these slides quite a lot of what goes on, but I think just coming back to what you tease out in the questions, the depth within HDW, which has developed over the 3 or 4 years it's been in existence.
Mm-hmm.
I think that's a really important message, I think, to get across, that those foundations and that depth will support the system really well in the future. And we have lots of conversations about that. And I think the one that I was probably as pleased about as anything when I see coming through is the cross-corneal piece of work, which came in very early on.
Yes.
Was a little tricky, but people took that away in the right spirit and actually developed the thinking, the research, the evidence, and brought it back, and it was successful. And I think it was one of the very early conversations I had with Susan, probably yourself, is that's a key part of what HDW is there to do, is to encourage people to develop that evidence base, because I think it helps the service hugely. And I think it's getting that into a rhythm of how we work, I think, is really important. I just thank you and Susan for the interaction we have as well, which I always find very enjoyable and informative.
Thanks, Steve.
Steve, thank you very much.
But I'm going to take it offline in the interest of time.
Chair, would you mind if I just made one very quick? I just wanted to well, sorry, apologies, Chair. I was with the delay in the line. Steve, firstly, thank you very much for your comments, and thank you also for your contribution in your Chief Executive role as well. And just to point out, I completely agree with you about the corneal cross-linking work. Also to highlight the fact that another piece of guidance that we published in our report at Freestyle Libre also followed a similar mechanism, where we published guidance 2 or 3 years ago, new evidence was generated, and we were able to revisit that and then publish supportive guidance on both those 2 technologies. So very important, our research provoking function as an organisation as well. Yeah. Thank you very much, Chair. Thank you for my allowance to kind of respond to that question.
Thanks, Peter. I had a question as well, but I'm going to take it offline. I'll email you and Sue and take it offline so that we can look at that issue. So in summing up, I thank you very much for the report and the informative discussion that we've had. So we note the contents of the report, but I also want to note for the minutes our pleasure and congratulations at you being awarded the David Haley Award, and please pass on behalf of the board, pass on congratulations to the staff involved in that. And I also wanted to congratulate you personally, Peter, on being appointed as NHS Chair on the National Institute for Clinical Excellence Appeals Panel, which is obviously testament to your reputation. So congratulations on that. We're very proud of that. And then finally, I just wanted to note that I attended a meeting last week about the public inquiry into COVID-19, the UK public inquiry into COVID-19, which was led by Catherine Ibbotson from the NHS Confed in England. And I'm afraid I took your name in vain in that meeting and said the appraisal work into COVID-19, which has been undertaken by HTW, should be included in the evidence that goes to public inquiry. And if you haven't said that already, they took that on board very much so, and I think they will be contacting you.
Thank you, Chair. Thank you for those kind comments and also that very pertinent comment. We are thinking very much along those lines as well within our organisation.
Thank you, Peter. Thank you very much. A 2-second warning, Mick. I'm going to change the agenda now and go to the performance report. If you're leaving us, Peter, bye for now and see you soon.
Thank you very much indeed, Chair. Thank you, everybody. Bye-bye.
Thank you. If we can then, we ought to have a break, but I'm going to postpone the break for one more item. which usually takes about 30 minutes, and I want to enable Mick to be able to contribute if he feels that's appropriate. So I'd like us to go to item 5, quality, safety and performance. And 5.1, Kath, I think you're going to introduce the report. You could be mindful
yes.
of time, Kath. I want there to be time for questions and discussion.
Okay, fine. So there's a, thanks, Chair. There's clearly, there's also the highlight report from the Quality, Safety and Performance Committee that is also on the agenda today, that provides a summary of the consideration of these reports, the detailed consideration of these reports that took place in that committee.
And note that in the minutes.
Yeah, and there might be items that that Vicky as chair wishes to raise in terms of relation to some of this, to some of the detail. But there were a number of issues that I've pulled out specifically just for us to highlight today. There are a couple of them that cover off the Velindre Cancer Service, and also one or two that relate to the Welsh Blood Service. The reports that we're reviewing today relate back, because obviously we're reviewing in arrears, relate back to the January period, which was when we were just coming out of that, or sort of still really sustaining the 4th wave of COVID, and responding to the challenges that the services, both services, had met during that December-January period. So that's just to remind us to set the context. So during this period, again, we were in a situation of alert in response to COVID, and both services have been operating under considerable pressure. And clearly that's demonstrated in some of the performance. But I think what I would like to say is that both services have worked extremely hard to sustain their performance in very difficult circumstances. And we've seen a considerable number of staff who yet again have been going over and above, have been cancelling leave, been working additional hours. And we've also relied on some considerable support from our patients and of course our blood donors, who've continued to come and support us again in difficult times with increasing rates of prevalence of COVID-19 in the general population. So that's the context in which I'm going to go into a little detail on a number of the services. I'll start with the Cancer Centre first. And I wanted to talk about our 2 core service areas. Firstly, SAT, and then I'm going to go on to onto radiotherapy. So in terms of SAT, we're continuing to experience pressure in terms of that delivery. As Stephen mentioned earlier on today, we pulled back all of that provision from the health boards, and we have managed to re-establish in Cwm Morgannwg the provision at Prince Charles, but we're still awaiting the provision to be re-established back out at Neville Hall. However, the point that I would like to make is that in terms of, although it adds pressure to our system in terms of delivering on site at the Cancer Centre, what it also does is it enables us to be more efficient in terms of the use of our staff to make sure that we're able to see as many patients as possible. So that's a real double-edged sword there in terms of wanting to deliver the services close to home for our patients, but also when we are operating under pressure to enable us to make the most of the staff that we have to be able to deliver service to as many patients as possible whilst still operating safely. So one of the things that we have done in the last couple of months is to establish a task and finish group to look at SAT, to really challenge ourselves in terms of a number of parameters. And that work is kindly being chaired for us by Nigel Downs, who's the Deputy Director of Nursing. And we're just putting some challenge into the system just to really make sure that we're looking at our space utilisation, our workforce alignment, and our recruitment, because we know one of our challenges in terms of being able to address some of the pressure we're under is going to be the continued recruitment of staff and being able to train them to have those specialist skills they need in SAT provision. So that piece of work is ongoing, and there will be there are still some small changes that we can make immediately, but also we're still looking to that medium term in terms of some of the changes to our staff and skill mix that we'll be introducing as well. I'll pause there just a second in case there's any question that anybody wants to ask around the SAC provision before I move on. Stephen, sorry, is it?
Yes, Chair, can I come in with a question, please?
Yes, sorry, Stephen. Yeah, sure.
Yes, that's it. Just wanted to pick up. I understand exactly what you're doing with SACT and how you're going to be doing this. But what you explained there, Kath, seems to be a very long process rather than some quick fixes to actually bring the management of this in a much more in a tighter timescale. What I couldn't pull from the report is the timescale you're working towards in order when you're hoping to be where you want to be as an organisation. I couldn't see that from the from the paperwork that's being provided. So, are you able to explain the timescale you're working towards, and when you hope to be in a position as an organisation to be providing SACT as sort of pre-COVID, if that's a reasonable assumption to make?
Okay, so we're already providing SACT at pre-COVID levels, and we have been for some considerable time. What we have seen is considerable increases in the amount of SACT provision. And of course, we're seeing patients that may have been delayed in their diagnosis because they haven't come forward during the pandemic that are coming through. So there's no simple answer to your question, but I'll give you the answer that is what we're doing. We're doing multiple things over multiple timeframes. So what we're seeing is quite a complex picture. We're seeing patients now that are coming through the system, and we're working with the health boards to understand what that's going to look like. We're seeing some variation between the different tumour sites coming through. We've seen some natural growth in SACT provision because we do see additional treatments that we can that we can use, which adds to that as well. So what we're doing to respond to all of that is three-pronged, really. One, the immediate things that we can do. We've done some immediate things, but we're actually challenging ourselves more about what more can we do and putting some more challenge into the system, challenge and support into the system to look at that. So at the moment, we're looking at how we can maximise the use of the skill mix, where there are any further treatments that we could move maybe into an ambulatory care setting, and we're exploring that. So some of those things will happen over the next few weeks and months. Then what we're also doing is we're out to recruitment for staff. Clearly, there are training requirements for those staff. So we're looking at the ways in which we can support that training, the way in which we can supplement it in any way to expedite it. And so that will give us over the next quarter and next 6 months. And then there's the return to the outreach out at Neville Hall, and we're working with Anara and Bevan on that. So multiple streams, and we're hoping that we will see some step changes within the next couple of months and 6 months. But in the meanwhile, we're putting every endeavour in to make sure that there are incremental increases as we can make them along the way. Sorry, that was quite a long-winded answer, but it wasn't a simple question.
No, I know it wasn't a simple question. That's why I asked it.
Yeah, the answer is everything every day.
Okay, but because I think Chair, with my indulgence, is I think it'd be really helpful is for the public to understand what you are doing, especially people maybe waiting or maybe using or accessing the service, to understand what's happening. Especially if you've got a family member maybe who's involved, who's having SACT, then to have that communication, that ongoing communication, to say what you're doing as an organisation. Reading the documentation that's on the board papers, it's a worrying sight. But I think with what you just said then, it does provide some assurance that you are grappling with it and you're dealing with it.
Mm-hmm. You look, Stephen, everything that Kath has just mentioned is contained in the narrative at the beginning of the report.
I did see that.
All of the processes that we're adopting in very difficult circumstances are set out. So the public have got access to that. Steve, do you want to come in?
I was going to come to a bit of this when we talk about the IMTP later on the agenda, Stephen. I think there's something about how we pull that together. It is in the report. But I think we will have a focus at each of the meetings, how we're deploying the operational response in the year, maybe as a separate piece that actually talks about that. And I was going to raise it this afternoon because I think having that focus as a board, I think would be really helpful for us as well. But as Donna says, it is in there. It's just how we get that focus.
Yeah, I appreciate that.
Is there anybody else with a hand up? So, Kath, carry on, please.
Yeah, okay, so radiotherapy. So again, I know in previous meetings we've discussed the complexity of the radiotherapy pathway in terms of the input that it requires, both from our medical team, from our medical physics team, and from our radiotherapy team. And again, similar to SACT, taking a multiple pronged approach to how we sustain our capacity and how we plan our capacity for the growth that we're going to be seeing going forward. And again, we'll discuss that this afternoon. But in terms specifically of our January performance, we are seeing patients returning in numbers that we are back to pre-COVID levels. You will recall that we've managed to increase the capacity that we have on our aging fleet of Linacs, and that we've done that through introducing hyperfractionation, which has created additional capacity for us. But of course, you might have less time on the machines for patients, but actually there is a complexity and a requirement for the planning that needs to be done for those additional patients coming through. So again, a multiple pronged approach in terms of our planning to expand capacity and make the most of what we've got. We've taken some immediate actions to make sure that we're able to make the best use of of both machines and the manpower that we have. But what we're also doing is we're still mapping pathways to look at where additional changes can be made. Some of these are quite complex in terms of the interdependencies with other elements of both the radiotherapy pathway and the knock-on to the time that some of our staff spend balance between SAC provision and radiotherapy provision, so that there are maybe a 3 month to 6 month impact on making changes to our processes. What we've also been doing is increasing the amount that we're making use of the Rutherford contract, and you'll see that an appendix to these papers gives you some details on the amount of use that we're making of that provision at the moment. Although obviously that is just an interim arrangement while we put some other changes in place. In terms of brachytherapy as well, the good news is that we're agreed the resources that we're going to require to increase the commissioned brachytherapy provision, and that has been agreed with WISC, and we're now starting to move towards the implementation of that additional capacity, which will take a number of months, but is the planning for which is underway. So I'm going to stop there.
Therapy. I can't see any hands up just yet. I've got 2 queries for you. One is a query it's on the table. It said 13 patients referred for radiology treatment with radical intent, didn't begin treatment within the 28 days. Fine. But what you said is that 3 out of those, 3 waited in excess of 50 days. And it would be helpful to us to know how much in excess of 50 days, and to have a comment about whether those patients were risk assessed. Was there any clinical harm that came to those patients? That's one comment. The second comment I've had is, if you stand back from this report on radiotherapy, I think there may be an issue in there that perhaps we're not bringing to the fore enough, because we're looking at reduced capacity because of Linux capacity, because of infection control measures, etc. But it does seem to me that planning is one of our biggest issues. You've mentioned in your report earlier about when you go to hyperfractionation, that causes pressure on planning, and then 3D palliative care, the reasons for some of the breaches is for 3D planning. So what's coming across to me as an impression is that we might be missing a trick by looking at all these other issues, when one of the big issues in there is our capacity for planning.
There's you're right, Chair. Sorry, I can see Mick wants to come in. But in terms of being able to explore that a little more with the board, it's one of the areas that we were going to share with you when we meet in April, and we've got a board development session, and we'll be having a session on radiotherapy that will enable us to explain in some more detail some of this, and perhaps we can then report that back at a subsequent board, if that's okay. The planning, if we could, I think it would be a good opportunity for us to be able to have a longer discussion out with with this meeting, and then to report some of that back. In terms of the patients that were that you reported, sorry, my iPad has just shut itself down while I was working off my notes. But there is an appendix at the end that with an explanation as to those. But that all of the breaches are alerted to the clinicians involved, and there's a rationale that is attached to each one of those. I don't know whether or not that was what Mick wanted to come on. I'm going to hand over to him.
What I think I'm interested in is, in excess of 50 days, I'd like to know, what the final time frame was, basically, and then was there any clinical harm? So, Mick, you were going to respond to some of those observations?
Yeah, thank you, Chair. I don't have a specific detailed answer to those individual patients today, I'm afraid, but more than happy to take that as an action, look into them and give you that reassurance. I think further, more detailed discussion around complexities of pathway, as Kath has suggested, would be very worthwhile and it'd be very appreciated. I know, both the SACT pathway and the radiotherapy pathway are complex. There's multiple steps, multiple professionals involved. All of those groups are struggling in terms of workforce numbers. And as Kath mentioned, if you make a change which might release capacity at one point, sometimes that means picking up extra work because something's more complicated at another point, and all of those are very critical pinch points.
Yeah.
And some staff are involved across many different parts of the pathway, so you pull into one and then you create a problem potentially somewhere else. So further detailed discussion would be very, very welcomed on that. I would just like to say a huge thank you to all our staff and patients and donors. You mentioned, Stephen, about keeping people informed. It can be very stressful if treatment is changed, and we have had to call people and let them know that things are being adjusted. The teams have really gone above and beyond in very difficult circumstances for a very long period of time. We've been in COVID now for 2 years, and it's still affecting services hugely. And staff members from all professional groups, whether they're patient-facing clinical staff or have other roles, have worked incredibly hard and continue to work really hard. And I just want to say thank you to all of them for keeping services going as well as they are.
Thanks, Mick. So, Kath, in terms of some of the issues I raised, they'll be picked up in a board development session. So I'm content with that. Mick, I'm sure the board would want to join me in echoing your sentiments of thank you to our staff. And I know Lynette Morgan would echo those sentiments as well. We met with her last week, and despite the dips in performance, she is very much aware of the Herculean efforts of our staff to keep the services running in the most difficult of circumstances, with workforce issues, with patient demand and so on. And I wouldn't want you to think for a moment that the board isn't aware and isn't wholly appreciative of the efforts that have been made by all of our staff over a 2-year period, which is it's absolutely phenomenal. It's a bit like, it's our finest hour almost, isn't it? That we've done everything we can to keep our services going, to, well, I can't say any more than that, really. I want to just echo your comments. Carl.
I'll get the hang of this now. Yeah, I just wanted to pick up, the Kath's point about the workforce, and so obviously there's a broader context, isn't it? So we've been relatively fortunate that we don't generally have a recruitment retention problem, but the workforce we just talked about, the physicists, oncologists, radiographers, there is a well-described national shortage for the last 5 to 10 years. So we're all operating in that context. So I think we just got to recognise that's not going to change. So what we are doing, we as an organisation with colleagues in North Wales and South West Wales, as the 3 tertiary cancer centres, we've done a piece of national work to look at different workforce models which are sustainable, so different skill mix, use of automation, artificial intelligence, all those things. So we've done a piece of work there. But perhaps more importantly, and Sarah, Kath and Nick might want to comment in terms of feeding that then into the work that HEIW are doing about a whole cancer workforce strategy. So I think it's just making sure that we see it in that broader context, that this is not a cancer problem, it's an NHS problem, isn't it, across all sorts of types of workforce. So and we've been relatively successful because we've been successful in being able to recruit and retain.
We've made some wonderful consultant appointments just recently, some amazing appointments. The thing, I'm very pleased to hear that, Carl, but I think the HEIW solution isn't a quick solution often, is it? You know, it's we're not going to have these people by Tuesday, are we?
There aren't, I mean, I'm not an expert in anything, but certainly not workforce, but there aren't any quick solutions, are there? And that's the whole point, isn't it? This is about, it's actually looking at all sorts of extended scope of practice. Nick talks about top of license, using automation, artificial intelligence to outline planning, segmentation. So it's a bit of all of those things until we get to the point where we can. So within that, there's an opportunity, isn't it, to do better quality well, better quality in a different way. So Nick and Sarah may wish to comment, because I'm going to step out of the workforce point.
Sarah, I'm going to call you in. I just want to ask, Mick, is your hand still up, or do you still want to come back in?
I'll come back in after Sarah. It is a new hand because I wanted to pick up on something, Carl, but I'll bow to Sarah's expertise.
Thank you, Mick.
Thank you, Mick. Thanks, Chair. So just to reiterate part of what Carl said, I think it's very important to recognise that we are now looking as an organisation, but also as a system, at short, medium and long-term impacts in terms of workforce change. Because as you say, Chair, some of these longer term pieces of work are not going to give us the solution we need tomorrow, next month, or even in 6 months' time. So we know we need to continue to work within our own system, within the organisation, but recognising now that we are very much aware we don't want to compete with other organisations for staff, because that actually doesn't help us overall or play our part within the system. So we're working nationally as workforce directors along with HEIW to make sure that we're pulling the levers in the best way that we can to ensure that we support the service on the ground. And the national piece of work that Carl describes is, of course, a very important piece of work, taking us slightly further forward into the future. The cancer strategy that HEIW are looking at, that again is looking at multi-professional impact around cancer services. But we know that the two things need to work in tandem. So as a system that we can get the best output that we can. But saying that, we also, of course, know that we need to work closely inside Velindre as a trust around our recruitment and retention. When we get people, we want to keep them. And we also want to present our face as an organisation in the most positive way we can to nationally and internationally within that workforce.
Thank you, Sarah. Mick, if you want to come back in.
I think Sarah said most of what I was going to say more eloquently than me. That just to reassure that it's that combination of working absolutely as hard as you can on the now, but also working on the future to have that long-term strategic vision and improvement. And balancing those two is difficult, but we very much have our eye on the current operational services and the future in terms of how we can make those longer-term strategic changes. Looking at it from getting the right staff with the right skills, working in the right facilities and within the right systems, with a focus on staff well-being as well. I think that's really important. Is sometimes that performance can come at a cost to individuals as they do that extra work. So that focus on making sure that our colleagues are healthy and looked after, I think, is a priority alongside all of these things.
Thank you, Mick. Can't see any other hands up. So, Kath?
Back to me then. So I'm just going to say thanks to Sarah and Mick and Carl for covering off the element around workforce planning that was intending to cover off when we get to the IMTP, because clearly that work is absolutely core to our delivery over the next few years. So I'm going to take us on to WBS, unless there's anything else on BCC that that anybody wish to raise. Don't
think so. No.
Okay, so so in terms of WBS, we have seen some variation in terms of our blood stocks in the past few months. I think that's indicated within the January report. But I am delighted to say that we have continued to rely on our excellent working relationship with hospital blood banks and for our donors in terms of being able to bring the stocks back from the slightly difficult position that we were in January at the beginning of the year. We weren't alone in that. That was a phenomenon that was being felt by each of the UK blood services, and clearly we're in daily contact with them to look at how we manage very closely across the UK in terms of our mutual support. But we did have to implement a blue alert. That's our sort of first step, which is hey, look, you know, we might be a bit short on our sort of initial raising of a challenge in terms of making sure we make the best use of the stock with hospital blood banks. And our response from them has enabled us to ride through January and to build our stocks. In the last couple of weeks, we've seen another slight drop in our O group blood. And again, we're working to make sure that we're able to rebalance that, although the other groups have maintained stability over the last few weeks. So just to give that update, that at the moment we're in a blue alert on O, but working with our donors to make sure that we can bring those stocks back to a satisfactory level. So the stock position was one of the things I wanted to identify for WBS, and then the two other elements that I wanted to bring out specifically, and that's our red cell reference laboratory. You can see from the RCI figures that we're continuing to struggle to meet the performance indicator, and we are seeing increasing demand from the health boards, and we're engaged with them to understand whether or not those are actually appropriate, that those tests are being sent to us as the referral centre for more complex cases. And we've also undertaken an audit to look at how we, whether or not we're actually working in the most appropriate way. But you will recall from previous times that we've discussed this, that this indicator includes both tests that are time critical and a range of tests that aren't time critical. So where we aren't able to meet the turnaround target, we are actually prioritising the time critical tests. So to just provide you with that assurance that the time critical tests are being met within the required time frame, and that we are looking to see how we can make efficiencies within the department and to work with the health boards around making sure that we're getting only the appropriate tests referred on to us. One of the things that will actually help in that department over the forthcoming months is the introduction of some new automated machinery, which will be able to make some of our testing processes more efficient. So we'll wait to see the outcome of that in forthcoming months. And then the other final thing that I wanted to touch upon is the fact that we are now starting to increase our use of the mouth swabs for recruiting non-blood donor potential bone marrow donors to our WBMDR register. And that's a piece of work that we're working on and we'll continue to work on over the forthcoming months, that will enable us to start to see increasing numbers of donors being added to that panel. Those are just the couple of things that I wanted to touch on from the WBS report, but again, happy to take any further questions that anybody's got. Sorry, Donna, you're on mute.
Kath, thank you for that. I just want to go back to cancer just for one moment and to note that we haven't had our usual discussion of Royal College targets versus cost targets that we usually have at this meeting, and to ask Carl if you can give us an update on where we are with reporting against both of those targets. You might, the board might think it curious that we haven't had that discussion, which we usually have. There's been work been going on behind the scenes, and Carl is going to report on it.
Yeah, I was thinking of Project 5 then, so I was looking forward to Project 5, but cost. Yeah, so Kath and I been discussing this with Welsh Government. Kath pulled together a really helpful paper for the board a while ago.
Yeah.
So essentially, we've got the cost target, which is right and proper in terms of reducing the pathways and so getting people to treatment quicker. I guess what we've also got is, so that's not a national target, it's just caused a bit of confusion for ourselves, for colleagues Stephen in the CHC, and also for patients understanding what's the actual target. So I've discussed that with Welsh Government over the last couple of weeks, and we've arrived at an agreed position whereby we will withdraw that from our current external reporting because it's confusing. We will clearly continue to monitor that internally because we always want to reduce our pathways.
Yeah.
In parallel, Welsh Government then will resurrect the conversation nationally, because one of the key points was an inconsistency of the reporting across the 3 tertiary cancer centres. So that's broadly unhelpful to all. So we've agreed that we will just sort of pause that as an external reported target. We will continue with those which are the RCR targets and recognised by law, so people still understand how long people have waited, quality of care, the experience of that care. And in parallel, Welsh Government will resurrect the cost discussion between themselves, the Cancer Network, the profession, to get to an agreed and consistent position, and then we'll bring that back in line when it becomes a national target. So I hope that makes sense. It's sort of clear in the decks a bit. We'll still work toward that because it's the right thing and proper thing to do. I think it's just getting the reporting clear and consistent across Wales.
So thank you both for your endeavours to do that. I for one, as an IM, find that very helpful.
Thank you.
So thank you for that. So going back to Welsh Blood, looking to see if there's any hands up. Kath, I just mentioned one thing. Under time expired platelets, in the narrative it says platelet expiry was above target. I think it should be below target, actually. It was because what is the platelet expiry was above target for January as a result of prudently managing the stock of the bank holidays that resulted in higher wastage. Wastage levels are compounded by a 7-day shelf life for this blood component. So I'm not quite sure there whether there was more wastage than we're comfortable than the target or less. From the narrative, I think it's below.
So I'll have a look at that. That's on page. I'm looking at that on the top of page 4. I think it's that we produced more platelets than demand required, as a result of which
that led to higher wastage, then, didn't it?
That led to higher wastage. Yeah. So the graph is showing the percentage of demand that we met. So we met. I think we produced 120% of demand of what demand required. But when we have uncertainty across the bank holidays, we have to increase our stock to make sure that our stocks are high enough to carry us through. So I think you're absolutely spot on. The outlining of that information in that way is one of the things we need to look at going forward, because that's not terribly helpful, really, is it?
Thanks, Kath. Before we move on to workforce and so on, I just wanted to note. And note in the minutes the continued excellent progress with healthcare acquired infections. Given all the difficulties the context that we've been describing, I think we're in year 8 now of not having an MHRA infection, and Nick, you might want to confirm that, and also that. We've only had one case of C. difficile and no harm came to the patient. So I just want to, I think we should record that. We've scrutinised all the things that may give us concern. We have to acknowledge things are going well. And I also want to note the sepsis bundle news scores compliance as well, because in the past there have been some issues around that, and that's a 100% score in there. All 6 patients were received all elements of the bundle within 1 hour. Within the context of what's going on, I think it is important that we acknowledge those achievements. Nick, and if you could pass best wishes on to our staff that are responsible for those services.
Thanks, Chair. And yes, it's 8 years since the Cancer Centre has had a MRSA bacteremia
which is amazing. And some health bodies have seen increasing prevalence of some organisms health required, but that's not been the case at Velindre. And what we're continuing to see through scrutiny is full compliance with audits around infection control practices, the staff in the cancer service, which is excellent.
Yeah, thank you. Mick, I think your hand is up.
Yes.
Is it? Yeah, Mick.
It is, Chair. I'm sorry. Could I excuse myself in the next 5 or 10 minutes? I've got a pre-existing clinical MDT that I need to be at.
Sure, we were expecting that, of course, Mick.
So apologies that I can't stay for longer. I very much wanted to come and support. If there's anything else I can help with before I go, I've probably got another 5 minutes, if that's okay.
Well, the next item, we're going on to the, Mick, you have to go when the clinic is the most important thing that you have to do. Thank you for your contribution up to this point. Kath, can I ask you if you'll take us to the next section of the report?
Chair, that was all. That was all I was intending to cover for WBS, and then we're moving on to the workforce element that I'm going to pass it over to Sarah for.
All right. Sorry, is that okay?
Thank you, Chair. Thank you, Kath. If I can just pick out some key points and then obviously any questions that we want to discuss. So what we've got in front of us here again, as Kath said, more generally, is the report to January. So, you know, obviously we've got more up-to-date data on some of these elements that I can share in a moment. Just wanted to pick up a point around PADR. What we can see obviously is that compliance levels are still lower than we would expect or want. And clearly, given everything that's been going on in terms of our service delivery and with our workforce, what I want to reassure the board really is that whilst perhaps formal PADR levels are not as high as they should be or need to be going forward, we have been having lots of work with managers to ensure that supportive discussions are taking place. So I just, whilst we're talking about formal PADR recording here, clearly the ongoing discussions and the ongoing support that people need and staff members need is one of the key factors in terms of well-being that is actually taking place. In terms of sickness levels then, as I said, this is the report to January, so we've got a 5.66 rolling sickness performance reported here. Actually, the data to the 26th of March is 6.01%. So we've seen a slightly worsening sickness percentage, and we would expect that given what we've heard in terms of service delivery. And of course, what we know is that the numbers of staff off sick are varying and fluctuating between departments, particularly difficult in the cancer centre over the last few weeks. And what we've seen numbers of staff off sick. So, for example, you know, we've got 16 staff were off sick with COVID as of the beginning of this week. But what we're also seeing there is the impact of special leave. That is, staff who are self-isolating. And, you know, just as a snapshot really at the beginning of this week, 4.53% of staff in the cancer centre were in that category special leave, and that's exactly the impact that Kath and Mick and others have described coming through those performance reports. So again, what we need to be assured of is that we are looking after the health, safety and well-being of staff who are isolating or off sick, but also those staff on the ground that are fluctuating and varying their ways of working to meet that service demand, and we've just described in some detail a moment ago. So we have got, of course, significant wellbeing support around people. We are encouraging people to come forward and ask for additional support if they need it. We have held engagement events with all staff, which had quite high attendance levels, where we were describing and discussing wellbeing need, what people feel they need in terms of support. We also had our Healthy and Engaged steering group meeting this week, where we were looking at the raft of measures that we've put around people, and the additional support and training for managers to actually be able to communicate and work with staff effectively, both those in work on the front line, and also those who've been working more remotely and away from the front line, because there's different impacts and different wellbeing issues on those two different types of staff.
And Sarah, and the offer for all of this goes out frequently on the comms, doesn't it? I notice it. You know, it's okay to say you're not okay.
Absolutely.
That message is going out. They're going out free. Everything you've just described is going out regularly on the daily comms.
It's going out in the daily comms. It's also going out to the divisional comms every week. But also we wrote individually to every member of staff at their home address.
That's right. I had a letter.
Yeah, just to reiterate the fact that not everybody reads the daily comms. So I had my name at the bottom of it. That went out from the executive team, really to just say again, it's okay not to be okay, and actually come forward, have conversations, and there's a number of routes that people can choose to take to have that.
Yeah.
Thank you, Chair. Those are the highlights really.
Then I would just want to add, I'll have a look to see anybody is wanting to come in, that compliance with statutory and mandatory, given the circumstances, you to be congratulated across the piece on that, because I think, you know, I've looked at a health board's compliance with statutory and mandatory, and it isn't anywhere near these figures. So I'm very pleased, I'm sure we all are, to note the compliance with statutory and mandatory against the 10 core statutory requirements. I got Matt, Martin, Gareth. Oh, that's me. And Steve. So Matt, if we could start with you.
Yeah, I just wanted to touch on the point that Sarah was putting around sickness, because it is an important point that we're still at heightened levels of sickness, and it sort of touches then in terms of the letter that came out from the Director General from Health and Social Care recently around giving us financial cover around the COVID response. So whilst policy may be changing around certain elements of COVID response, clearly sickness levels remain very high, and there is a cost to that for us to maintain that capacity that's lost. So it's really encouraging we have that financial cover really to help us backfill and do the best we can in terms of covering those gaps. So I just want to make that link really.
Thanks, Mark. It's important. Martin?
Just to make a general point with this whole paper, I'm hugely impressed by the quality of the debate we were able to have today. I think that comes to the covering paper and Kath and Sarah's sort of explanations of the important things. So we've got to talk about the issue as well, the quality of the paper, which is good.
Yes.
I think that's really, really impressive. There's still a bit of work, as I think we've talked about identifying what's a statutory target and what's a stretch target, and how we sort of make sure we differentiate those things. And I guess the last question specifically for Sarah is, despite the changes in government regulation about self-isolation, I presume we're still encouraging our staff to self-isolate if they are testing positive.
Yes, absolutely. I'm sure Nick can give more detail on this as well.
Yes, we have got a variation. So for staff who are frontline caring for patients who are extremely clinically vulnerable, so our cancer population, those are the patients who have had direct contact with somebody with COVID, we are still not having them in that direct patient-facing role. So we can redeploy them into different roles, or they can work from home. But the rest of the staff, you know, we have got different arrangements for, but it's that number of staff in the cancer, which is why the cancer service is the area that's most under pressure.
Okay, Martin. Thank you. Gareth, please.
Thank you. And I just want to preface it by saying this is not a criticism, just a gentle question around the PADR figures. That it seems that corporate is the, should I say, the worst offending part of the organisation, and one would have expected corporate maybe to be able to get it more right than the other parts, and just wondering whether there is any particular reason why the figure is so low.
Shall I pick that up, Chair? Yes, you're absolutely right, Gareth. And I don't think there's any particular reason. What I do know is that we are having detailed discussions as an executive team in terms of how we can make sure that we bring those numbers back in line with the compliance levels that we need. We certainly put plans in place now to make sure those dates are in the diary. We of course know that we in all our teams have been diverted to respond to the COVID situation, but that notwithstanding, as you rightly say, actually those levels are lower than they are in the divisions.
And I think that we must tighten up on the issue, and I put myself here, when PDR is completed, get it onto the electronic staff record. There's elements of that system as well, as I say.
Absolutely.
And I'm doing that myself. So, Steve.
Just coming back to the statutory mandatory, I hadn't seen these papers until I got back recently. So I got my mic on now. So just coming back to the statutory mandatory, I hadn't seen the papers in the building for this because I've been away. But I was really pleased with it. So what I'd like to do is pick it up in the comms when we send out, because actually that's down to people.
Yeah.
I think we just need to thank them because it is really important.
Mm-hmm.
But given all the other messaging about where we are and what we're having to deal with, for people to have that focus as well, I think is really important for us as an organisation. I think that's recognising it and getting the message out from the board, just highlights how important it is and expressing our thanks.
Thank you, Steve. I think that's, I'm sure Sarah will agree on that, and I will take that forward. I can't see any other hands up, so we have, I think, thoroughly discussed the performance report. We've scrutinised it well. We've reviewed its contents, and we received that report. So we're going to now have a 10-minute break. If I could take us then to 4.10 on the agenda, which is the Chair's update. I don't intend to speak to any of the issues in the paper, but I'll take any questions on them. But I do want to add 2 items which are quite recent. The first is that yesterday, one of our charity ambassadors, Wayne Griffiths, met with Buffy Williams, the Senedd member for the Rhondda, on the Senedd steps to discuss the fundraising for his aspect of the charity, which is in memory of his daughter, Rhian, and that during the plenary session in the Chambre, Buffy mentioned the work that's taking place at Velindre and was highly praised the work of Velindre and commended our work to those in the Chambre. So I think that's worth noting. I've responded to Wayne to tell him to say thank you for organising that. And the second point I just want to point out, I'm not even sure if this should be in a Chair's report, but I want to point it out, is that Hannah Rooson, who is the lead for education, Nick, I haven't got that title right, but she has arranged 2 days of seminars on the 26th and the 27th of April. The programme is so interesting. It's mainly around cancer, but not entirely. There's some guest speakers and so on. And I've spoken with Hannah and she's very happy. It's 2 whole days, a very full programme, very exciting topics. She's happy that you can dip in and dip out. So that's what I'm intending to do. So if anybody, if we can send the programme around, and if you contact Hannah, she'll send you a link. Is that okay, Nikki? So I'll take any questions on the content of my report. And if not, then I will hand over to the Chief Exec for his report. Steve.
Excuse me, I start coughing just as my mic goes on. Thank you, Chair. I'll take the report as read. I had intended, if we'd done in a different order, to focus on the COVID. I won't dwell on this for too long, but just to reiterate to some extent and capture what's been said in a lot of the items today about the pressure that remains from COVID. I know we're meeting in person for the first time for 2 years. Mm-hmm. So life is starting to return to normal, but actually underlying that, there's a huge amount of pressure in the system. And I know we've said it before, how much we appreciate everything that our staff are doing. And I think it's quite stark when Sarah adds up the special leave plus the sickness. We got 1 in 10 members of staff off at the beginning of the week. So the pressure that puts on everybody else, and it fluctuates. And as I always say to staff, it's how we support each other as we move in and out of those situations where some of us are off and some of us are back in is really important, because otherwise it just raises stress in individuals if they know that things aren't being done. So I think that's a really important point. And then the flow of that into how we actually handle INTP and our annual plan for next year becomes an important link for me, but I will pick that up later on in the agenda. Because it sets the context of the uncertainties that we all face on a daily basis, and the challenges our staff are facing at the moment, and how we plan in that environment as well. So I just wanted to say that, and just briefly in terms of the new hospital, the competitive dialogue continues at pace, very intense as we speak, and very intense period at the moment. And we'll keep everybody updated as that progresses. So I'm happy to take any questions on anything else.
Can't see any hands up on the screen. Just I can't see any hands up on the screen, no hands up in the room. So we accept and note Steve's report, but I just wanted to also draw attention to the work that the Trust is involved with as far as the conflict in Ukraine is concerned. And thank you for including that in your report, Steve. So we now come to item 5.20 in the report, which is the financial report from the period November and December 2021, and I'm going to invite Matthew Bunce to present this item, take the Trust Board through the key financial position and performance for that period. Matt.
Thanks, Chair. So the report is for the period to February 22. I'm going to assume everyone's read it. I'm just going to flag that the three key performance indicators were all green at February, and I've got no reason to believe that they won't continue to be. We are on the last day of the financial year, so next week we'll be closing down the month 12 position, and of course then spent 4 weeks producing the accounts. And so the report is for noting, and then we can move on to questions if you've got any questions. And of course there's a detailed report attached.
Again, thank you, Matt. No hands up on screen. Martin, Gav, was that your hand up then? No, sorry, okay. Yeah, sold. So just Martin then, Martin.
Again, just a comment on a question is just to recognise that given the extraordinary uncertainty, staff absences, COVID impact, to get to a position, I'm not getting ahead of myself here, but we're at the 31st of March today, and as Matt says, if we do indeed deliver a set of green indicators, that's a terrific performance again this year.
Yeah, so thanks for that comment, and I will pass the message back to the finance team, because they have been under immense pressure. There's no doubt about that, with sickness and difficulties of working in isolation like we all have at home and not having that contact with team members. So thanks a lot.
Thank you, Martin. Vicky? Are you on?
Right, we've got one on. It really just a comment, because I think we've heard, haven't we, this morning all about the complexity of the challenges and the staff sickness and absences. And Sarah and Matt are working forward-looking in terms of triangulating some of those issues, because I think the challenges from a financial point of view looking forward, Matt, are going to be more challenging next year. And it's actually how we get a true picture of that, both through QSP and then at the board, because I think we need to know and understand how it's all knitting together. And so they're working on a joint report, which to some degree triangulates with that. It then ultimately needs to move towards triangulating with the operational performance and the outcomes. So I think it's just for the board to note that, Chair. Thank you.
Thanks, Vicky. You're absolutely right. And it is getting more closely aligned. With every QSP meeting, it's a bit more closely aligned. And we look forward to that developing. We're on a journey there. And I think it's going to be very good when we do get that fully aligned. And endorse Martin's comments. It looks like we're heading for a very good end of year position, Matt, and reiterate the thanks to all the team. However, we're in for a more difficult time going for reasons which everybody knows, because it's affecting their daily lives, which is energy prices, inflation, and so on and so forth. It's affecting everybody's lives, and it's going to affect us as well. So I know that, Matt, you're having to think very hard about planning for next year.
Yeah, thanks, Chair. And obviously that'll be part of the IMGP discussion later on.
Yeah.
Those are the key things that you flagged, the big sort of risk areas. And as I said earlier, the recent letter from Welsh Government will help us manage some of those risks in terms of financial cover. So that's helpful. But that risk around COVID recovery still remains, and all the conversation here around capacity, demand and sickness plays into that. Thank you, Matt.
So I'm looking up, I can't see anybody on screen with a hand up. So thanks, Matt, for the report, which we note its contents. And so we come to 5.30, which is the risk register. And so, Lauren, I think this is your report to introduce. So over to you. I'm going to try and find it just because I can.
Thank you, Chair. So just to take the board to the key points noted on page 2, as the cover report demonstrates, and you'll see the detail in the appendices, the next phase of focus for us as a collective team is to ensure that the actions for each of the risks are clear and time-bound and owned. There's a bit of a mixture at the moment in the way in which the fields and datex are being used between articulating controls and articulating actions, which we're supporting risk owners and their teams on, in ensuring that those two things are distinct and clearly recorded separately. That's particularly for the cancer services and corporate risks. As you'll see from the detail, the WBS risks are do separate them out in that way at the moment in terms of controls and actions. That's something that we discussed in EMB and also at the QSP committee last week. The second point that we discussed in Executive Management Board earlier in the month was when we reviewed the risk profile, the digital health and care record project risks needed some work in terms of the overall calibration of those risks according to the rest of the profile, and also the a review of whether the EMB view they could potentially be consolidated. So it's not only calibrating the risk score, but also the level of detail in some of those project risks, and that action is currently underway. And then linking to the point on Steve's CEO report, so the geopolitical risks in terms of the conflict in Ukraine are being worked through from a business continuity perspective. So from a supply chain sort of direct impact wise, as some of the wider aspects of impact on us as an organisation. And that is being will be considered at the next Executive Management Board, but it probably will be appropriate to share that out of cycle so that the board isn't waiting until May for those risks to play through into the board reporting. So we'll share that in as when the Executive Management Board have reviewed in a couple of weeks. And we can come back to the actual detail of the risk profile. As the only other comments I was going to make to start with are just to draw the attention of the board to section 3, which starts on page 12, which describes some of the action that's been taken as a result of the feedback from this meeting and Audit Committee and Quality, Safety and Performance Committee in the January cycle. So that talks through some of the progress or closure of those always useful aspects of feedback. So thank you, Chair.
Thank you, Lauren. Gareth, I can see your hand up. Nobody's hand up is on screen. So I've got Gareth and Martin. Gareth first, please.
Thank you, Chair. Lauren, if I could take you please to page 9 of the risk paper. The two risks, which are 2329 and 2328. That they currently have a risk rating of 16, and the target rating appears to be 16 as well. And just to understand, please, why we're not looking to reduce that target, that risk rating.
Thank you, Gareth. So it was actually a question that Vicky raised for the Quality Safety and Performance Committee as well. That is how the DHCR project have been put them into the system. That is, so it's not a reporting error from Datex. So as part of the review that EMB has asked the project team to do with their risks, that feedback on those two risks has been specifically passed to them as well. Thank you.
Thank you.
Okay, Gareth. Yeah, thank you, Martin.
Thanks, Chair. Just recognising that this is a journey and we're still on that journey. I think it's helpful to see the 20s and 16s drawn out. I'm not entirely sure that this list of risks necessarily reflect accurately the thing that we discussed as a board in terms of the top issues. So, for example, some of the 20s, I don't think probably are 20s in the global scale of things. And I think Lauren, you kind of alluded to that in terms of the digital healthcare records stuff. And just more generally, then what we need to do is to get a little bit more detail around current controls versus what else we're going to do to get the number down from the current rating to the target rating. And then obviously then nail that down into who and when. And that kind of detail needs to come through. But I think it's, we're on the journey, and I recognise that this is a huge improvement again. Thanks.
So would you have to respond to that, Lauren?
Completely agree. Yeah, that summarises very well the focus that we are now at for this next period of the journey. Thank you.
I'm just intrigued by the, we don't think, given the discussions of the top risks are necessarily here, we need to reflect on that and take that up, Martin, and have a think about that.
I guess just to say that the risk register is bottom up, but it's also kind of top down.
Yeah.
And if you ask the people in this room what the top 10 risks are, it wouldn't necessarily be this 10. So that's we just need to be sure that we get that sort of triangulation right.
Which is this the lens that we look at it from, isn't it? As opposed to what the lens, as you say, people from the bottom up look at it. So I think that's a very helpful comment, which we take on board. So we're asked to note the risk levels 20 and 16 as reported in the Trust Risk Register, and note the ongoing developments of the Trust's risk framework, which is a lovely segue into the next agenda item, which is 5.40, which is the Trust Assurance Framework. This is the next iteration of the populated Trust Assurance Framework. Everybody all right? Okay, that's fine. The report sets out the developmental pathway to take, next steps, and the plans for further development and operationalisation within the Trust. So, Lauren, I think this is your item again to introduce.
Thank you, Chair. So, the Trust Assurance Framework, so reflecting on the last conversation on the risk register, would be interesting to have some discussion, because this is absolutely top down in terms of what as an exec and board combined teams we set over the last 6 months or so as our 6 months to a year as our long-term strategic risks in not achieving our long-term strategic plan. So the 10 risks there have continued to be developed by each of the owners, and a summary of some of the developments on each of those risks since the last reporting period in January are summarised in the cover paper. And the points then referenced in 3.7, I just wanted to draw the board's attention to before we went into any of the particular risks that anyone would like to, in terms of some of the discussion in the Strategic Development Committee last week on this framework. So we talked about, there were sort of 3 key themes that we talked about. We had a really good discussion in the committee. So one was around how the concept of issues are reflected in this framework, and that these are the strategic risks, but if there were issues in the organisation, they would be reflected in different ways through the levels of assurance, whether that be through first line or from external assurance. We talked about the links between this strategic view of risks in the assurance framework and then the risk register. That's something that we also have discussed in the Quality, Safety and Performance Committee, and then the ongoing development of not just the interaction between the risk register and the assurance framework, which should be fairly straightforward in that we'll be able to link the risks on DATEX from the risk register to the strategic risks in the trust assurance framework, and that's fairly straightforward. And then the bits that we want to do is then link the relevant metrics from both the performance and quality frameworks as those frameworks are developed. So against each of these risks, all of those, the alignment of the risk register and then the appropriate metrics from quality and performance frameworks will all be linked going forwards, and that's the plan for this year's work plan. And then the third point was, again, building on Martin's reflection of what does this all mean as an overall risk landscape, and how we can continue to mature our management and oversight of risk to be able to take a step back and look at the impact of a number of these risks crystallising at the same time, and what different scenarios may to sort of reverse stress testing concept of what adverse scenario would we want to test, and then which of these risks would materialise to get us to that point, and that helps focus us in terms of the management and prioritisation. Thank you, Chair.
Thank you, Lauren. Martin, I thought you might want to contribute.
Again, this is really helpful, and the detail in the appendix is really helpful to understand the work that's been done to get to where we are. I think that point about plate spin is really interesting, but how many plates do we need to keep in here, and how many fall at once to create that sort of critical tipping point is a really interesting point to discuss. The other one about issues is some organisations have an issues log as well as a risk register. I'm not sure we need to dance on the head of a pin in terms of understanding the distinctions of those. I mean, they're both problems, and both things we need to fix. Some are a bit newer than others. I also had the interesting differentiation is that if it's a risk, you can smell it. If it's an issue, you're standing in it. It's kind of the sort of definition of sort of how you understand it. But either way, it's a problem, and you need to resolve it, I guess. And just finally, the other side of having the assurance framework is that we have that things in place to actually make sure we pick up the opportunities as well, the upside of all of this. So the risk of something going right rather than the risk of something going wrong, and that's kind of nice as well. So to have that, and we've got that in spades with TCS, haven't we?
Yeah. I could see Hillary's hand up, but I just wondered in relation to the issues issue, Gareth, if you wanted to comment on that, because it's something that you've been concerned about.
Thank you, Chair. Your helpful analogy, Martin. I need to get it clear in my own head whether that is the way this organisation views the distinction between issues and risks, because I had been under the impression, maybe wrongly, that the issues were a more serious manifestation of a risk, that it gets escalated to an issue. I may have that wrong, and I appreciate that a paper has been prepared for TCS around that, and I need to revisit that paper. But I do think we need to be clear that all of the risks appear to be covered in a lot of different places with different processes. We just need to make absolutely clear that the issues aren't missed merely because they aren't capable of being recorded on DATEX.
On DATEX, yeah, which we've discussed. Steve, do you want to? I'll come back. Hillary, can Steve respond to that, or?
I might say it's a specific but general.
Okay, Hillary, and then Vicky, and then Stephen come in at the end. Hillary.
Thank you. Sorry if this was already covered. The sound dipped for me for a minute, but a trust assurance framework for me links directly into the organisation's strategic objectives and breaks down the links to reaching those objectives and the risks that are mitigated along the way. So I don't know where we are along that journey and when we're anticipating reaching that point.
Thanks, Hilary. Steve, do you want to answer that? Or Lauren?
Specifically, I suppose, Lauren, but it does relate to the point I want to come back in there.
So that's how the initial list of 9 was created. And then when we went through, as in reviewing the long-term objectives and plans, and then the 10th one in terms of governance was added when we went through the review of that in various committees last summer. In terms of the work plan for this year, the actual risks themselves obviously could be reviewed at any time by the owners, but there's a specific point. So following the approval of the IMTP, we will then review the trust assurance framework. So that will come through again over the summer with each of the exec leads speaking with where there's particular links to independent members as well, having some discussion before, and then that being brought through committees over the course of towards the end of the summer. So that annual cycle following each IMTP will happen on the content. Does that help, Hilary?
Yeah, well, I suppose it does, because we're in a moving feast at the minute, and I suppose it's a little bit of a chicken and egg situation. But if we're achieving an IMTP plan, it's also good to know that the board assurance framework works with that from day one, if you see what I mean. But maybe it's a conversation we can have offline.
Thanks, Hilary. So I now have Steve, then Vicky.
I suspect, Karen, I would say broadly the same thing. We've got a lot of things coming together, almost strategies, IMTP, we've got a TAF being developed, we've got a lot more clear water. I think we'd probably do a session as a board to actually bring that all together. We need to timeline that, and I think a conversation with Donna about how we use the board development sessions to get into that debate, and we can pick up the issue at that session as well, Gareth, and we can have that conversation together. I just think we've got strategies coming through. We signed off the trust one. We got strategic objectives. We got IMTP. We got all the the ingredients to have a pretty rich conversation about where that takes us, which will give us a refreshed TAF risk areas for the future.
Yeah, I want to do that.
So Vicky, I mean, I think it's just building on Steve and Hilary's point, because I think the risk descriptors for the TAF is really helpful, and I fully support Lauren because it's a complex web that we have to weave to get it all together. But I think what would be really helpful for particularly myself and I'm sure the rest of the board is to understand the strategic objective, then the risk against that objective, and therefore the delivery. And I think when we come on to talk about the IMTP, it'll make much more sense because that's set out very structured in that approach, and then actually adopting those strategic objectives, because looking at this, we can then see the business that we're transacting through the board and understand the risk against the delivery. And that's how it's all going to come together. It's just actually this summary of the risk descriptors. It'd be really helpful to have the specific wording of the strategic objectives along with some of the expected actions.
I think Lauren is nodding approval to that. So Carl,
yeah, thanks. Yeah, I'm not going to repeat the conversation. I guess just for Vicky's point, it's really important. I guess Steve's point, in an ideal world, you'd start this in sequential order. I think what we've got is different pieces arriving at slightly out of sequence. So we'll put that in place, because I think what we're missing at the minute is the top bit. So we've got all the things in place, the strategic goals, we've got 5 goals, and then we can see that basically that line of sight from what the organisation is trying to achieve over the 5 to 10 to 15 year period, and what that means right the way down on the shop floor. The other interesting bit, broadly speaking, and somebody tell I'm wrong now, but if you took those strategic risks, so forget the service for the minute, but the big things that try and drive the organisation forward, broadly speaking, there's similar strategic risks for most organisations, aren't there, about people, about resource, about capability, about technology. So there's also something broadly sort of comforting in the fact that organisations are broadly similar beasts, aren't they? The content and the industry might be different, but you still need good people with a good plan, good skills, you know, stakeholder engagement, good understanding of customer experience and feedback. So I think it's in that sort of space as well that it gives us some assurance that we're well along the right path. But you're right, we do just need now to land the top bit so it all makes more sense and we can tell a far clearer story.
I can't see any other hands up. So endorsing that comment, we're asked to endorse the updated trust assurance framework dashboard that's going to be submitted to Trust Board. Note the progress made in the next steps in supporting the continued development and operatisation of the trust assurance framework. That's twice I can't say that word. I promise I've only had coffee to drink. And to note that we've agreed, I think, around the table that some of the issues that we've raised today, that Vicky has raised, Gareth and Martin in particular, that we'll take forward into a board development session. It's important we get them right. It would be wonderful if the world was perfect and things happen sequentially, but they just don't happen sequentially. They happen, well, I wouldn't use the word chaotically, but they happen at inconvenient times. So, but we have to have a framework that is resilient to that. And I think we would like to co-produce that with you along the lines that have been discussed. So Lauren, in your role, pick that up for a board development session.
Absolutely. No, the discussion's so useful, thank you.
So we were behind time, colleagues, but I think we've made up a little bit of time now. So I'm going to keep going. We're going to do the next item, which is 7.10, which is the board committee structure, and then we'll break for lunch. Okay, so board committee structure, this is going to be led by Lauren. You remember, colleagues, just a quick bit of context from me, that pre-COVID, we won't be saying BC and AD any longer. We'll be saying pre-COVID, post-COVID, won't we? So pre-COVID, we began looking at our committee structure and proposing a revised structure for our committees. And then we've implemented it, always with the understanding that in a year we would have reviewed it. And then during that year, we've had so many curveballs which have been COVID related. But nevertheless, Lauren and her team have looked at the committee structure to date, and I'm going to invite you to tell us what you found so far, Lauren. Thank you.
Thank you, Chair. So the yeah, it does seem like a while ago now that we had 9 committees previously that were in scope of our review, and because there were a number that we in terms of our hosted obligations that we weren't reviewing. And as a result of that review, we've ended up with our 5 core committees and 2 subcommittees. And the agreement when we approved that as a board at the end of 2020 is that in a year's time, we would then revisit the structure and reconfirm as a board whether we were content to continue. Over the last number of months, there's been some discussion around how we complete this exercise, and this paper brings together a number of sources of internal and external assurance. It's a thorough job, and Emma's led on this, so thank you to Emma in coordinating the work. I think it's fair to say it's been a desktop exercise in that respect, because it's brought together existing forms of assurance into one place and consolidated them. In discussing the next steps and recommendations with the chair and with Steve over the last few days, the reflection has been, although this has been operating for we're reviewing it within the timescales that we agreed that we would. Clearly, the last year has not been a typical year for the organisation, and there's been a number of different changes in terms of chairs of the committees, etc. during that time. So although the recommendation doesn't say this at the moment, the proposal is that we add on a recommendation to review again in another year's time. And the final bit I just wanted to add to that was to sort of go back to the way in which this exercise has been completed, that over the course of the next number of months, as we've talked about in a couple of times in the meeting, around having conversations in terms of that step back, how all these different elements coming together, the frameworks, the committee structure framework being a key part of that, how we work as a board, and the conversations that Steve, Donna and I, and the rest of the board will be having. So we will be having with the rest of the board on all of those different elements and getting people's views and opinions on those things. So more of a conversation over the next year rather than just the desktop review sort of element of it. So that's all I was going to say up front, Chair. Thank you.
Thank you, Lauren. So there's several papers in this little bundle. I'm looking to see if anybody, Gareth, you have a hand up, and then Vicky. So Gareth first, please.
Thank you, Chair. Just two comments. First, on what you just said, Lauren, that this is going to happen over the next year. I suppose I'd like to think that it might happen a bit sooner than that, but that we progress these issues to the extent there are any sooner than maybe over 12 months. So I don't know whether he literally meant it's going to take 12 months.
No, sorry, I meant no. So the conversation's to start now. Sorry, I meant in terms of agreeing this was the structure that we'd carry on with as a board in terms of our committee structure, that we'd in effect today be putting another year review endpoint on it. But the conversation's to start immediately. Yeah.
Okay, fine, thank you. The second point was in relation to paragraph 3.6.4 of the which refers to hosted organisations' assurance and reporting arrangements. That seems to imply that a piece of work has already been undertaken regarding the accountability arrangements for particularly shared services. I'm not sure, unless I missed it, we've seen the output from that review, and it seems to suggest it's going to be implemented in March 2022. And you'll know from conversations we've had elsewhere that this is an issue I'm particularly concerned about. So it would be helpful, please, to see what the deliverable is from that piece of work that appears to be.
Yeah, apologies. On reflection, that isn't. On reflection, that paragraph is a bit too definitive, because in reality, there's a lot still going on in terms of defining the next steps for the relationship between us and shared services in particular. So Vicky and Martin and I are currently speaking with Tracy Myhill, the new chair of shared services, and Neil, along with Steve and Donna, as to how some of that may develop, in particular with, well, in terms of the two committees, the role of QSP and the Shared Service Audit Committee. And what we have discussed with Tracy and Neil is that they're going to attend the board development session in June, so that actually, as these conversations and plans and thoughts develop, that there's work going on outside of that, but then as a board we can discuss that with shared services, with Neil and Tracy together in a board development session in June. So I can send out a revised version of 3.6.4, because actually I think, well, that work over the last few weeks has happened since this report was originally written, which has superseded it.
Do we just send a revised version, or do we have a careful minute of the conversation?
Yeah, I can minute a version of that paragraph. Yeah.
Okay, thanks, Lauren.
I'm happy with that. That we amend, or that we reflect on the minutes the conversation.
Yeah. Yeah, thank you.
I'm agreeing wholeheartedly with both of you. We're still on a bit of a journey, particularly with the QSP reports that we get. Can't speak for audit because I don't attend, but I think, you've been going a bit longer, having a shared services audit than we have QSP. So early days. Vicky.
I think just picking up some of the points in the paper and your reference to the groups that will be commencing and starting to support the subboard committees. I think it's really important that we actually get some distillation of papers, because at the moment we've still got a lot of detail in papers, and actually from those subgroups that actually we get more succinct and specific to the subboard committees, so that we're very clear about what the risks are, what the issues for discussion are, and reduce the size of the papers, because actually that's going to help the debate, not hinder it. So you're not looking at as much data, just the relevant data to the pertinent issues that need to be discussed. And I think that will only be supported by the groups that will meet underneath, because they will go through the detail. But actually you don't want to see the same papers coming through each of those groups. You want to see the distillation of that. So we are focused on those key issues. And that's really important for us as a board. It's also important for me as chair of QSP to then provide assurance to the board in terms of those issues that have been discussed at QSP.
Thanks, Vicky, for that. And I think we've got a session which is 8 o'clock one morning next week, Pound for Fend, where we can discuss report writing and our requirements and issues. Gosh, I'll never be able to say the word issues without using quotes or thinking about it very carefully. Thank you, Gareth, for that. So we've got an opportunity to input into that next week. I think it's Thursday or something at 8 o'clock. Martin, and Hilary, is your hand up? So I think you were first before Martin, actually. So Hilary.
Thank you, Chair. My question was, and maybe it's a process issue, what would have been useful is to have the heads of terms of each committee structure sitting under the board to make sure that we're not missing anything, but maybe as part of the process we're expected to see that next time.
Okay. Yeah, thank you, Heather. Great.
Thank you.
Yeah, thank you.
Because I can't always quite see, you know, the logo, which is in white. When you put your electronic hand up, it goes on top of that little logo. It's very difficult to see. So if I miss anybody out, just please shout. It's not intentional. I promise you. So Martin, I think you were next.
I think my one reflection is that I think I'm in favour of the committee structure. It seems to work well. However, as somebody who doesn't sit on the two major committees, on the QSP and the strategic development committees, we rely quite heavily on the highlight reports. So I don't think they should be in consent. I think that it's there for information, but I think we need to have a discussion, have the chance, an opportunity to have a discussion with the chair of those committees, just to rather than drag it out of consent. If we need to say anything about it, I think there should be substantive items on the agenda. The other thing I think is about nuancing what papers go to those committees, what papers come here to the board, and we don't want to double count. Absolutely, we don't want to second guess those conversations either. So it's a really interesting balance. And the other thing is just absolutely volume of papers. I echo completely Vicky's point about we need to sort of, you know, are we saying that every word on all 907 pages they're giving us today have been fully digested and understood? I suspect the answer is going to be no. So it's relevant. What's relevant to send us.
So thank you, Martin. We've only just started putting highlight reports into consent. And of course, they can be pulled out, but I'm very happy, very comfortable that we discuss that issue in this review.
Yeah, absolutely.
And I think alongside that, we need to discuss what needs to go into the highlight reports. Are they too short? Are they too long? How much detail needs to be in there, and to get some idea of what we need to put in there. But if I can assure you that I'll pick that, might leave things as they are for a minute because we've only just done it, and we'll pick that up in this review.
And I think that hierarchy about it's a TCS highlight report is probably less important because that's already gone through another stage, which is the main committees.
Yeah,
which
absolutely. Absolutely. I think Stephen Allen, I think your hand is up.
That is, Chair, thank you. And I just wanted to reiterate what Martin was just saying then about the highlight reports. I think from a public point of view, looking at the reports, it's a good snapshot for the public to actually pick up on the key issues that are being flagged up to via those committees to the board. So I think I would support Martin's comment then, and I know you have a further discussion, but moving them out of consent and putting them back into substantive discussions going forward for the highlight reports from the, from those main committees will be really helpful. And can I come back with another point, Chair? Are you discussing the Quality Safety Annual Report yet, or is that coming up as a separate item?
So it's one of the sources of assurance that we used for this review. Stephen. So yes, within this item.
In that case, Chair, can I just flag up one issue there? Then, if that's okay, on the trust on the quality safety report, I think there's a missed opportunity here to again provide some wider assurance, not only to the board but obviously to the public who may read that report. There's no mention of Audit Wales or the CHC involvement within those to provide that external scrutiny. I think that may be helpful going forward.
Stephen, I'm ever so sorry. You kind of were a bit echoey and it went a bit in and out of signal. I didn't quite catch what you were saying then. Could you repeat it?
Of course I can. Is that better, Chair? Can you hear me better now?
Much better.
Thank you. Yeah, what I was saying is that first and foremost, I would just picking up on Martin's point about the highlight reports being available and discussed at board. I think would be really helpful. I appreciate you having a conversation on that shortly. I think from a public point of view, we will find that quite helpful because it does give the public a snapshot of what those committees are discussing. There's a lot goes to those committees. I think really helpful. The second point then, Chair, which was on the annual report for the Quality Safety Committee, I think there's missed opportunity here to actually put something in there about the input of Audit Wales and CHC into that report, insofar as providing that public and external assurance, only to the board, but obviously the public who may read that report going forward. There isn't a mention of our involvement in any way, shape, or form. I appreciate we are attendees, we are not participants as such, but we have speaking rights. I think it'd be really helpful to put that in as a level of assurance.
I think there's nods around the table, Stephen, so I think you've got agreement on that matter.
Yeah, very good point.
Going forward.
And it was one of the first to be done in last year's work plan cycle, so we're due for that again soon, Stephen, so we'll ensure that's incorporated and for the other committees.
Thank you.
Thank you.
Kate, I think I can see your hand up.
Yes, I was going to say that I've got some views on sort of committee effectiveness in its widest sense through work we're doing on quality governance currently, but also picking up that wider intelligence towards our structured assessment later in the year. You know, if I've fed some of that back to Vicky and Martin in part of ongoing meetings that we've had, but yeah, if you want to have a chat or with Lauren for some of those views, to give earlier heads up rather than wait for the reports, then I'm more than happy to do so.
Thanks, Kate. I think that'll be very helpful. Steve, do you want to comment on that? Somebody's phone is pinging, is it, man?
I'm more than happy with that, Kate, and it links in with some of the socialising that Lauren talks about. We're looking for broad input into that, so I suspect what we want to do. Lauren and I having a conversation about who we'd include, but it's not an exclusive club, and I think I'd like to meet with Stephen and you, Kate, in terms of your input into that, just to understand your views on how we operate, because I think it's very easy to go from structured report to structured report, but I think teasing out how we work with people and just getting underneath those things, I think will add huge value over the coming months in terms of how we develop operationally the way we work. And we've already picked up some things this morning. There'll be other things that other people will want to, and as I said to Lauren earlier, it's a conversation with execs as well as IMs about how all this is working, because I think we all know we can refine it and make it work smoothly.
Thanks, Steve. I can see Martin's hand is up again. I'm just looking around the table. Martin, I think it's just you.
Just to contextualise this, I would go back to Lauren's put these papers in for a very good reason. That there's both an internal audit and the structured assessment paper here. And we should echo the context of this conversation is not to say that things are wrong or it's a continual journey. So the key message in that structured assessment says quite clearly the trust is well governed.
Yeah.
I think we shouldn't lose sight of that.
Yeah.
We just hope we make it better and more efficient. We're not saying it's broken and needs to be fixed. We can continue the journey.
Yeah.
It's the continuous improvement journey, isn't it, Martin?
Yes.
It's a real opportunity for us to take stock of a very difficult 2 years of how we want to operate in the next 2 years. And I think I didn't want to lose that as part of this conversation.
That's a very helpful balance and perspective to put on things, Martin. Thank you. Right, so we've discussed and reviewed the findings of the new board committee structure following its inaugural year of operation, noting that it was an atypical year due to COVID. And I would like to take this opportunity to thank colleagues who completed the various reviews and surveys which have informed that. Note the progress made to date in continuing to strengthen and develop our operating arrangements. And whereas we endorse the next steps to support the recommended actions and key areas of focus identified in the 2022-23 reporting period, we want to add to those next steps that we will look to socialise, if you like, these findings across the organisation in the coming months, and in going forward, that we would include CHC and structured assessment analysis in this review and report. Okay, have I left anything out of what we just discussed and agreed? Thank you. So now Lauren suggests that we now break for lunch. This is one of the most important items on our agenda today, actually, because we're going to be asked today to approve the IMTP for 2022-25 for submission to Welsh Government, which would take place later today if it's approved. Carl, is that right?
Yeah, we're all,
So this paper, as it's been developed, has been to several committees, including it was a strategic development committee which Stephen chairs last week, where there were lots of comments and discussion had about the IMTP. So just to make sure, this is not the first time we are seeing this plan at this board meeting. We've had several opportunities to look at it as it's being developed, and it's a very significant piece of work. And I just want to, thank everybody that's been involved in putting this together. And Kath, I think you're going to lead on this item.
Chair.
What?
We have a different running order for who's going to speak to this, just to be aware. I'm going to start.
Not on my paper here, you're not.
No, not that I knew.
No, I'm teasing.
So,
okay.
So the order we're going to go, I'm just going to do a bit of a general where we are. Then I'm going to hand over to Carl, who will take us through the development date and some of the non-operational service parts. Then I'm going to hand over to Kath. We'll talk about the operational aspects, and then Matt. So we have a rounded, and we're not going to make it really long. It's just to give you a feel for, because I'm aware we've had discussions on it before.
Yeah.
But I think it's really important in this public board meeting. We do have that opportunity here today.
Before we start, Vicky, you had your hand up. Did you want to say something before we start?
I think it was only just to add to say that we've had an earlier circulation of this to give IMs who haven't been on those committees time to review it in some detail. So it's just to add 2 points.
Thanks, Vicky. Yeah, that's absolutely right. So, Steve, hand over to you then.
Thank you, Chair. First of all, I'd like to thank all the team who've worked off, not on. First of all, I'd like to thank all the team who worked tirelessly to get this developed over what has been a really difficult few months. And I don't want to labour that, but I think it is really important we have that. And just to say, this plan is probably one of the most difficult plans I think I've ever been involved in having to put together, and I've been doing these sorts of things for a fairly long time now, and tricky in terms of how do you frame this plan for a year which is going to have more uncertainties than I think we've ever faced, both in terms of what's going to hit us, but also in terms of how the whole system's going to respond to coming waves, because there will be other consequentials out of COVID, and I suspect surges over the coming months and years. So it's been really tricky, which has been reflected in the way Welsh Government handled the change in environment and context for the plan that we've been asked to develop. And
just to say, even up to, I think, Tuesday even, we were still getting developments on the funding flows information that come through. I'm sure Matt will pick that up. So it's a plan, and it does mention that in the papers, that has got to have a real element of agility in it. And we need to be certain about how what level we want to operate this plan at. And I think my last comment before I hand over to Carl is that context of how we operationalise in that on a month-by-month basis, which links into Stephen's comments earlier, some of the earlier discussion, I think is really important. And I don't want to lose that in the performance report. I think there's something about teasing it out. And I haven't worked through, even in my mind yet, what that looks like, but I think it's about the board being clear about what the operationalisation issues that Kath and the team are facing every day, but and how far we get it on that. So I think that will be really helpful. And at that point, I'll shut up and I'll hand over to Carl.
Yeah, thanks, Steve. So I'll just put a couple of salient points in the cover paper and just sort of give a bit of a shape to it. So a couple of important matters to note. First of all, it's a statutory requirement, as the paper says. You know, it's in the Finance Act that we're going to have a plan. Bless you. Second, then to note, it's the first time in I think 3 years that we're going back now to a 3-year planning horizon. But as the cover paper says, that's still within a relative pragmatism from everybody in the healthcare system, that whilst we're talking about a 3-year horizon, the focus very much still remains on next year, given all the uncertainty and everything else. We're trying to make sure that we try to understand better and plan accordingly. So that's the sort of framing. I guess just a bit about process, because that's also important. And I did make this point at the committee a couple of weeks ago. There's no such thing as, you know, the end of a year and the start of another. It's just a day. So the first point for us really was the things which haven't been done, and you'll see later on in our bless you in our where are we this year against our actions. That's the starting one. We took a baseline assessment of what we set out to do in the year, and then started to understand where was our baseline. Second bit then was around working with the boards. We had a number of board development sessions trying to understand what the board requires from the organisation, sort of stand to frame the plan. The third then obviously is working with our LHB partners. They're our partners as well as our commissioners. So building on their health needs analysis of the populations that they serve and we support. And also, I know Stephen's here, we've had a number of conversations with the CHC, and those will continue. So it's just getting that sense, and let's not forgetting the most important people in this, the patients, the donors and the staff we serve and who work for us. So we've also got their views. So that's the process. We've then taken you through our planning framework, and then it's now gone EMB back to our commissioners, and Matt and I met with the commissioners a number of times, Matt particularly, just to understand quality, performance, affordability and funding. So that's the very high level process we've been through, which gets us to today. So in terms of the actual plan itself, I think it's I'm quite excited actually in a funny way, because it is a bit of transition for us. We've gone from a 1-year to a 3-year, but I think the important part for us is the framing of the plan. So at a national level, we've got the Wellbeing of Future Generations Act, which for me is everything we need to be thinking about, because it covers everything. Beneath that, then we've also obviously got a range of policies, Healthier Wales, we've got blood and cancer policies, everything else. I think importantly for us this year is the fact that we are now starting to bring in our strategic refresh. So the board approved the trust strategy in 2032, and we will start to see the other things coming through. So that does start to provide a strategic picture for us to frame this plan against. And I think it picks up the earlier point made in the TAF and the risk, you know, we've got a 3-year plan, but actually what's it trying to deliver in 5 and 10 years? So I think this plan starts to actually fall out of now those 5 strategic goals we agreed in the trust strategy and some of the key strategic priorities. So we've now got that link, the golden thread between what the organisation is trying to achieve and what this plan does to take us forward in 3-year cycles. So that's the first thing. The second thing as well for me, it does then start to articulate, hopefully, the great work that the Cancer Service and the Blood Service have done in their 5-year plans. The Cancer Service has got a 10-year plan in the last 5 years, and Alan and Blood Service colleagues have now got a 5-year plan to take us through to 2027. So we've got a high-level strategic intent, we've got the service clarity, and then we've got the 3-year IMTP. The third bit I wanted to draw the board's attention to really was I guess the golden thread, the quality safety experience, and Nicola, Kath, Jazz, I know she's not here today, really, really important that we actually make sure that runs right the way through everything we do. And I hope that comes through. But also, I think what this plan does is try to deliver 3 particular things. One, we've got to be excellent at our core services, and that's our primary function. Hopefully this plan sets out how we're going to achieve that. Our ambition, but also, as Kath will talk about, how we operationalise that. I think the second thing, it starts to try and pick up our broader role in the system. So moving into that leadership space where we've got the expertise and the mandate from our health board partners and other partners to start to take a step forward in some of the spaces where we can actually add real value on behalf of the system. And the third part for me, hopefully this plan starts to demonstrate our next, I think, step in our maturity as an organisation. So transitioning from, when I say this not flippantly, providing intervention and healthcare services, making people better, to doing that as our primary job, but also starting to get into the system transition from ill health to well-being. So what's our role in adding value in terms of public health, prevention, primary care, so on and so forth? We're not a senior partner, we don't have statutory responsibility, but there's an awful lot we can and will do to try and help others to make some of those wicked issue problems in Wales go away. So that's the sort of transition that this plan starts to set out. And then as a result of that, it starts to pick up some of the wider policy intentions as well. So we've talked a lot about decarbonisation, that's now a requirement. So stopping the things that make people ill happening. So decarbonisation, climate emergency. The second one around the foundational economy. We've got an organisation with about a £400 million budget if we include shared services. So how do we use that through our people, our infrastructure, our procurement to actually do good things? And the last bit really is this broader sense of social values, not just health, but actually how can we start to work with others to drive prosperity through employment, through apprenticeships, the obvious things, but actually starting to think about our assets and how they can provide opportunities to add social value to communities we serve. So I've jumped, covered quite a lot of ground there, but I think that's the basic frame of this 3-year plan. It is only a starter for 10 because we have still got to start to bleed in the strategies which have yet to come to the board. But I think what I'm trying to hopefully articulate is, whilst this is still very much a year 1 plan in many respects, as we start to work our way through year 1 and get certainty on the number of matters, we'll then start to see our strategic intentions start to really come in over the next couple of years. So that's, I guess, the sort of semi-easy bit. I'm just going to pause there first for any questions, just to make sure the board are happy we're going in the right direction, and then perhaps hand over to Kath, who's got the really hard job of delivering ambition in year 1 with colleagues. So I'll just pause there just to check that we've got the right direction to travel from the board's perspective.
I can't see any hands up, Carl. One point which can... Oh, is there a hand up?
I thought you were going to ask a question, Alex.
Sorry, is there a hand up? Yeah, sorry.
I just did that.
Thank you very much. No hands. Right, Vicky.
I think just a comment because, and I did say this on the email, I think the actual document itself is really helpfully structured to the way that you've just talked, Carol, which is really helpful. So it's much easier to read than a lot of documents I've read before. And that structured way, supported by some of the diagrams that support the principles, is just really helpful because then you're getting your head around it without having to plough through loads of narratives. So just thank you to you and the team, Carol.
It was a very straightforward read, I have to say. I just want to make one comment at this point, which could save some colleagues contemplating this as we go through. So it's something we've mentioned. There is an intention to develop an easy read 3 to 5 pages version in due course, because we did mention, didn't we, want an exec summary and so on. So that doesn't appear here, no. But there is the intention to develop that. So some colleagues might be thinking of raising that as an issue. So if I can begin by giving assurance that that is going to come.
Jay, can I just make 2 quick points then? So that was one of them. Stephen, I think you've kindly offered to help us with that. And we've got a meeting in the diary. We expect that to be done by the early part of May and get that out. I was trying to digitise that as well, so it's a simple story. And the second part, and I'll hand to Kath then, picks up the conversation this morning about the golden thread. So we've got the strategy, got the policy, we've got the plan, we've got the performance management framework, the quality assurance framework, and then the TAF, everything else. But the bit of work we'll do if the board are happy to prove that, then is to map the objectives to the goals. So I think there's a recommendation, I think, in the structured assessment, which I think Katrina's here, which we can then really show the line of sight between what actions deliver what objectives to help us move closer towards our goals. So that's, if the board do approve this plan today, that's a piece of work that we'll do outside the meeting. So I'm
thanks, Carl. So are you handing over to Kath at this point?
Yeah, I think Kath's there. Yeah.
Yep, I'm with you. So I've got some notes and some points that I would just like to highlight for the record. But before I do that, just reflecting on the points made in the last few minutes, we have got the new trust strategy, but as Carl mentions, and there's the new one coming through for WBS that will sit underneath that. However, if we actually look at what our intention is, we're really carrying on the direction of travel that we've been working through for a number of years. So all of the actions and activities in here are really just the continuity of work that we started in the main well before COVID-19 ever became a word that we were now sadly so familiar with. And the challenge for us is actually to make sure that we maintain some flexibility and agility in terms of balancing the work that we're doing to keep the service delivery on a day-to-day basis, as we currently are, with all of the challenges that we know we face through each and every wave of the pandemic, with also the bigger system change and service changes that we're looking to implement. So that's very much the theme of the plans that we've put in the IMTP, and that's around balancing, maintaining safe service delivery today and meeting the challenges of the demand that's coming through, whilst also managing to reach our aspirations for the service change. And quite startling when you actually think about how all the years line up. Towards the end of this 3-year cycle, we'll really be quite a while down the way to planning our transition to the new cancer centre. So when you actually start to sort of focus on that, that's quite an awakening, really, in terms of the operational challenge that is going to be, but also in terms of the opportunities that brings us. So I'm going to take the two operational divisions separately in terms of the operationalisation of the plan. The actual action plan that you've got as part of the document is still quite high level. So underneath those, for both of the divisions, there are two things. One is the more detailed plan that sits below this again. But also we started to map the dependencies between all of these pieces of work, because as I said, there's going to have to be some flexibility as things move. And also then with each of them, there are the plans that we will require, the support that we'll require from the cross-cutting services such as workforce and OD, digital, quality and safety team. So all the cross-cutting threads that there are to support us with those corporate services to enable us to deliver the changes that we're required to take forward. So for WBS, a couple of the really big pieces of work that we're going to be looking at in the next 3 years, but with this focus on the next 12 months. We know that we're working towards looking at plasma fractionation as part of the UK-wide endeavour, and we're still having discussions around what that might look like. So that's maybe looking a little further towards the back end of this year than we might have anticipated. Still in the early days of discussion on that. We've got the laboratory modernisation programme that will be linked to the infrastructure development on site at Talbot Green, and making sure that we're able to make the most use of technology to look at potential automation of some of our laboratory processes. That's going to be very much around process and flow. And clearly, just because that focuses on laboratory doesn't mean that we won't be carrying on the cycles of continuous improvement in terms of what the blood collection looks like on clinic, and also looking at the way in which we're able to return to our communities. Very mindful of the fact that we've drawn back our collection to bigger clinic, what are called venues, that's the word, to bigger clinic venues. And it's required us during COVID to move back from some of the local communities that support us. So very much focused on returning our collection back out to those sites. And then finally for WBS, the other element that I wanted to highlight is the Welsh Bone Marrow Donor Registry, and the fact that through the early part of this next coming 12 months, we're going to be looking at what our strategy for the next phase of development of the Bone Marrow Donor Registry is, and looking forward to that piece of work in the forthcoming months. I'm just going to pause there to see if anyone's got any questions about WBS before I move on to the delivery of the plan within the Cancer Centre.
Thanks, Kath. I can't see any hands up. Kath, I just wonder what your take is on whether the timescales you've just provided for plasma fractionation, are we likely to see significant developments within this 1 year plan or in this 3 year format? Because it doesn't seem to be moving at a pace.
It isn't. There are UK-wide discussions that are happening at government, and we're not party to the outcome of those discussions yet. But as soon as we are, we'll let you know. So at the moment, it's one of those things where we're waiting for news. However, what we have done is done a considerable amount of preparatory work, so that when we do know what the plan is, we'll be able to enact our requirements pretty quickly. So as usual, you'd expect nothing less from us. We're well prepared. But at the moment, awaiting clarification. So then moving on to the Cancer Centre. As I mentioned, 3 years within which we have considerable number of large programmes of work. We mentioned earlier on today the outreach, and recognising that within this next 3 year period, we're going to have to make sure that we have got that outreach fully enabled. Sorry, to take a step back a second. I think we've got two arms of delivery again. One is the work and the endeavours to make sure that we're able to meet the demand as it comes through from the health boards within this next 12-month period, working very closely with our health board colleagues to understand the actions that they're taking to develop their diagnostic services, and all of the other elements of their services that patients require before they reach us. And we'll be monitoring all of that through the senior leadership team meeting on a regular basis. And then the other side is really around how we're progressing service development. And again, there are a number of areas where we'll be looking at that service development. And in fact, they touch right across all of the services that we deliver. And clearly that service development and transformation is going to be taken forward under the Velindre Futures banner. So under that Velindre Futures, the big pieces of work that we'll be doing, the implementation of the DHCR, so that's the replacement of the CANISC system that we're anticipating will be later in the year, probably in about another 6 months. And then we're also going to be seeing the end of the procurement phase and the implementation phase starting for the fleet of Linacs and the integrated radiotherapy solution. Just those 2 pieces of work are phenomenal in terms of the service change that they potentiate and the work that they require. But clearly then as well, we'll be seeing our implementation of all of the regional aspirations that we have with our partner health boards through the Velindre app programme, and some of the implementation elements from Nuffield as well. And then sitting underneath that, there are a myriad of other pieces of work that we're bringing to the fore, including the primary care, our aspirations in terms of supporting primary care, and making sure that we're able to provide our advice and support to primary care as well. And as Carl highlighted earlier on when we were talking about the performance report, one of the key elements of that is going to be making sure that we're planning our workforce, both in terms of our immediate need and our plans for the next 12 months to meet increasing demand, but also looking from the medium term and the longer term in terms of that workforce planning, recognising that we need to make the most of advanced and consultant level practice, non-medical consultant level practice, that we need to make the best use of our medical workforce, that in a lot of areas we're in shortage professions. And we're going to be doing a piece of work to start to try and take some actions now to preempt where we need to be within the next 3 to 5 years. And on top of that, as I mentioned, planning for the radiotherapy satellite centre, and then starting the transitional plan through into the new cancer centre. So lots of big things, lots of medium-sized things, and of course the ongoing what's it called? Cycles. That's what I'm looking for. Cycles of service improvement that you would expect on a sort of month-to-month basis as well. So quite an ambitious programme, but an exciting one.
Thanks, Kath. I can see Martin's got his hand up in the room. Martin, I think it's over to you.
Thank you, Chair. Kath, you talk about planning, and that's really helpful to understand the growth assumptions. I wonder if you can talk a little bit more about the growth in service, the tables on page 40, various ranges of radiotherapy, radiology, etc. I'm just taken by the news item yesterday about the struggles at the Grange in Iron Bevan, where they made planning assumptions about people turning up at the A&E, and that's been blown out of the water completely, and they're off by a factor of 50%. I just wonder what these planning assumptions are based on. Are they based on returning to normality? Are they based on enormous backlogs that we think are in the system, and how are we going to cater for that? Is this our ability to deliver a service, or our ability, or what we think the demand might be?
Shall I? I'll answer that by just telling you the process that we've been through to reach these figures. You might recall that over the last year or so, we've been doing a piece of work with the Welsh Government Delivery Unit, Improvement Cymru, and Health Board partners to look at the longitudinal the data across the patient pathway from primary care through to us in Velindre. And we've made really good use of that to take us back to that 1920 baseline, and then to look at what we've experienced so far, to put the trajectories that we had based some of the TCS assumptions on, and to look at the number of patients for each health board that hadn't come through the system as might have been expected during COVID. So we've pulled all of that information together. We've been out and discussed it with the health boards and checked the assumptions. And that's the basis on which the information that we're providing you with is the planning assumptions that we're making. We've shared those planning assumptions in the commissioners' meeting with health boards. But as you said, they're only as good as they are on the day. But we've had an awful lot of support in terms of looking at it, and we've really sort of assessed the data as best we can. The important thing that we need to do now is to make sure that we continually review our experience against those assumptions and to keep projecting forward. And that we're doing that on a regular basis, and we'll be sharing that through our meetings, our commissioner meetings in collaboration with Matt and the finance team, and we'll continue updating these projections and the data sets that we're holding as we're able to do so. There's some assumptions in there about what the health boards will do, but clearly some of them are still determining what their final plans actually look like. And then the enactment of plans, of course, then can be something different as well, because there's so many permutations and things that could happen. So I think the important thing to do is to note that we've done our best to make this compile this projection. We've had a comprehensive discussion with the health boards around how we've got to them, and then we will now follow this up by monitoring them on an ongoing basis and continuing that dialogue.
So, Councillor, we're a much less complicated organisation in many ways than the big health boards, but I'm sure, because I was there, that an Iron Bevan had just the same conversations with their partners as you've just been outlining in that response to Martin. So, and this is time critical, because once the footprint is decided, so if we don't get this right, it's going to be difficult for us to envisage remedies in terms of space, isn't it? If this isn't got right.
Yeah, Kath, I understand that the projection is the point in time. I guess that in reality there's a range of possible outcomes, and I presume this is the midpoint of those things. This is not worst case scenario or best case scenario. This is some sort of best guess of what the number might be.
Yeah.
It'll be amended each year, I guess, but that the chair's point is a really important one when we come to construction of a new building about capacity, and that fits within the overall TCS strategy. That's the important point to make, isn't it?
Steve, you wanted to come in, then Carl, and then Vicky.
And it won't be 8% each month from it. It will be like this. It's going to be really messy. And this goes back to my opening comments, really. We're going to have to be very agile. It's why I want to come back sort of quarterly to the board, and we're clear about where we've got to, because this will not be a straight line. And the situation in Bevan yesterday shows the sort of things that are going to face the system, and that will affect us. And it'll be within specialties, it'll be within sites, it'll be within hospitals. And what we've done is put some flexibility by having some external capacity in to be able to flex up and down. I don't know what the answer is going to be, Martin, but it's not going to be a straight line, and we're going to have to. But what I wanted to do is make sure we had a capacity plan that's based on something which we could sit down with our staff to engage with and talk to them about what the basis on which we plan for a year. And also take them with us on that particular journey as well, because I think that's been really important, because I think we've been a bit blind on some of that, and the staff have absorbed in the situation we described this morning everything that's come with that, and we still have I call it good performance in terms of responding to patients who come our way. So again, it's a way of us being far more planful about how we react, but it's not going to be a straight line.
Yeah, hang this one, telling me meeting's over now. Yeah, no, I think there's some really valid points in that. I mean, I guess I wouldn't want to comment on other people's systems. It's just I think there's a point of commonality, there's a point of difference. I just wanted to highlight. I think the commonality is the one we described this morning. Broadly speaking, one of the issues in Wales, not just the Grange, is workforce, isn't it? Just having the ability to put people in the roles to be able to manage people who need their help. So that's a commonality. I think the one point of difference for us is, I think the point described where the other thing in there is patient flow, isn't it? It's actually the discharge bit. So it's similar but slightly different, isn't it? So we don't have at the minute the same challenges around discharge, in terms of patients who would come into our plan assumptions assume that we'll have relatively effective discharge to home, because most but not all of our services are broadly ambulatory care by nature, aren't they? So about 95% of our care is ambulatory, whereby a lot of the health care is inpatient waiting for discharge back to rehab. So I haven't got the numbers, I'm not with the evidence base, but I think there is a point of difference there, Nick.
Yeah, I mean, we do have a small number of discharge challenges because we have the fast track end of life discharge, and we have pathways back into health boards where clearly transport and bed availability is a challenge. So it's a smaller percentage for us than it is for health boards, but they do exist. Albeit, I would say on a positive note, the Cancer Centre, certainly in the last year, have worked tirelessly with health board colleagues to improve pathways, and therefore the delayed discharges we have is negligible now compared with what we had previously.
One in the last reporting period, Nicola, when you think that how many, I think there are over 1,000 across Wales, and we contribute one to that, which was ultimately managed. So that's really helpful. I got Vicky and then Stephen Allen. So Vicky, you were next.
Okay. I mean, I think we've got significant delivery aims that we're talking about. And I think based on the assumption point that Martin made, I think there's something that we need to work together as a board to get the performance management framework and the reports. So we're actually looking at year to date. So we're not focusing down on Steve's point in terms of that in-month variation. We're actually looking at the delivery so far and actually what we need to do in order to retrieve the position in order to deliver at the end of the year. So and at the moment we haven't got that. We've got in-month data, and actually the cumulative position year to date would be really helpful. I know, Kath, you've got plans to do that within the report, but I think it's something that would be really helpful for the board.
I think I'm going to call Stephen Allen in next. Thank you, Vicky. Stephen Harris, is that your hand up? Yeah, okay. Stephen Allen first and then you, Stephen.
Thank you, Chair, and thank you. Yes, we have been involved significantly with your development of the IMTP, and thanks to Carl and the team for all their hard work in doing what they've been doing to put it together for you. I just wanted to pick up on one thing. I think it's more of a general question, and it links possibly to another part of your agenda today, is how are you going to engage with the wider community, not just those who access cancer services now, but how, you know, what I think you need to put in there, which is a bit more detail of how you're going to engage with the wider community and take on their views and comments as this plan is then rolled out over the next 3 years, and how you, where needs be, you will adapt your plan going forward to address some of the concerns or mitigate some of the issues that may be coming your way through your inpatient engagement framework. But I couldn't see whether that was in there somewhere. So just wanted to flag that up with you, as we're interested to know how you intend to go out now and engage on this going forward, and how you intend to take this forward from a public and patient engagement one, not just those who access services, but the wider community who may well be coming down the stream to you in the future.
I'm just going to try and respond to Stephen.
I think so. That's a really good question, and I think you picked the first part up yourself, Stephen. I don't know if Catherine knows them with us, Lauren. Just in terms of the developing patient engagement and donor framework, I think that starts to provide the frame, doesn't it, to set up why people want to engage with us, and B, the ways in which we can make it easy for them to do so. And so Nick will want to come in there. The second bit, on a more practical level, I think we found really helpful, Stephen, is actually doing simple things well. So we've used quite simple surveys, which we've asked the CHC to fill in, haven't we, about some questions on what do you want from this state, you know, what do you want from your experience. So I think it's been relatively straightforward to do. It's been really, really rich in the information we've received. So I think there's a whole range of other things, but I think Nick will want to comment with Kath on. It's got to be based in a frame, and I think it's the patient engagement and donor framework, which it deals with people who come to us, but also I think the other thing we need to think is about people who might not come to us for those services, but may have an interest in making a contribution in all sorts of ways. So I think it's through that framework, and I'll pass across to Nick and Kath, who've been instrumental in with Norn in developing that.
Thank you,
Nick,
Carl.
you're going to address that point, yeah, yes, please, then.
And you know, it is a piece of work, as colleagues will know, through the engagement framework that's been developed, that we are, you know, we are strengthening the arrangements, and to support us in that, we've expanded the use of the patient experience software that we've had in use in the trust for the last year to include a patient engagement module that will actually allow us to much better actually capture and work with our public on this very matter. So that's going to be put in place in the next couple of months. So the amount of engagement that we will be able to facilitate as an organisation will be far in excess to what we've done previously. So we will look forward to updating the board in future updates on how that's going as well, and in particular to the IMTP and the delivery of the requirements outlined in that. I don't know whether Kath wants to add anything.
I think Lauren might want to add something to that. Nick, that's very helpful, thank you.
Catherine may be about to say the same thing in terms of timeframes. I was just going to bring the board's attention to the next couple of steps. So in the diary for this, in terms of the patient engagement framework, which is to come to Strategic Development Committee, which between Stephen, Carl and I were looking at the revised date for that in May, but that'll be within the first couple of weeks of May to allow discussion at the committee there before coming to board at the next meeting at the end of May.
I do apologise. I'm just not going to get it. The other thing, Steve, is the experience we've had from that bit of work we did on engaging with young people as well. So we got broader sustainability agenda, haven't we? And also, so the stuff we did using Minecraft, getting across South East Wales, all the children's views on what the hospital and the environment and the asset might look like. So there's a lot of learning there we need to capitalise on. I don't know what that looks like just yet, but I think that also feeds into your broader question of engaging with people rather than engaging with patients and donors. There's a broader sort of conversation to be had as well. So I think we need to try and make sure that's not lost, not the piece of work itself, but the principle of that work.
Stephen Harris, sorry. The number of times I have to switch this on and off. We now want me off when I'm not speaking because I think Hillary's picking up a bit of buzz. Stephen Harris, next please, and then Hillary.
Okay, thank you, Chair. I just wanted to go back to the previous part of the conversation, which flowed from Kath's description of the in terms of capacity and demand going forward, the unpredictability of that and the potential impact, of course, ultimately on many things, including, for example, the new cancer centre. But I also like to tie that all the way back almost to the start of our meeting, when I raised the concerns and the issues about the outreach services, and perhaps just to expand slightly on the discussion we had as IMs about outreach services, because clearly making sure we progress those and deliver those as originally planned is important in terms of the new cancer centre. But as I guess we can all recognise, some of this increased demand that may come along may have to be delivered through those outreach services. So again, just doubly emphasising, I suppose, the importance of now starting to have added impetus on the outreach activities, because they will ensure we have the right size cancer centre, but they will also help in delivering against some of these increased, I suppose, demands for capacity and delivery, exactly in line with the sort of areas that Kath is describing.
Thanks, Stephen. I had a note that Kath wants to come in. Is it on this point, Kath? Because Hillary's next to speak. But if you want to address the issue,
thanks. So there's a couple of things. I want to talk about the patient engagement work and Stephen on that. So I'm happy to wait and see what Hillary wants to say and then cover it all off in one go, if that helps.
Okay, Hillary, please.
Yeah, okay, thank you, Chair. No, my point was back to the patient engagement one, and to say that, you know, I chaired a stakeholder group to pull a lot of the frame together, and I'm sure that Kath will update on where we are with it at the minute.
Thanks, Hillary. I'm sure that will come forward. That will be included when we get the patient engagement framework in May, Lauren?
It will.
It will, yeah. Thank you. Kath.
Yeah, so so in response to Stephen Allen's comment about the population, clearly that whole public engagement exercise is one that we will continue to develop. But just to give you an assurance that in the work that we did around the patient engagement, the term patient engagement is being used as shorthand for patients, families and carers. So actually, in terms of reaching out to families and carers, we are still reaching that wider element of the population. And it's really important that we get their opinion, because they're not only there as on behalf of the patient, but they are there in their right as members of the public as well. But our anticipation is that our donor engagement, our patient engagement and our public engagement will sit together and will firmly be set in the context of Future Generations Act as well. So we are in the process of signing off the patient engagement work within the exec management team to bring back to Hillary as the chair mentioned, to bring it to the strategic development committee, and look forward to doing that. And we're already making plans, as Nick mentioned. We've had the idea to work with Nick on using the patient experience platform, which is going to give us a really good head start in terms of being able to enact some of the establishment of the patient panel and things like that over the next couple of months. So look forward to chatting that through with you soon. Stephen, in relation to your comments about the outreach and about the impact on TCS, I think we're clearly in a really well-informed position now in terms of our data to supplement the information that we've previously made some of the planning assumptions on. So I think through the TCS programme, we will continue to look at the information as it becomes available and to check some of those assumptions, the planning assumptions that we're making. So that will be part in terms of part of that wider programme of work in collaboration with the health boards and also our own internal planning for our own internal capacity. We will be making sure, in fact, the outreach work is already being fully established in terms of the discussions we're having with the health boards, in terms of just the reverting back post-COVID. It's all becoming one longitudinal piece of work as opposed to separate elements. So that very clearly is sort of a integral part of the work programme at the moment. Sorry, you're on mute.
Thank you, Kath. Does that finish your part and I move on to Matt, or have you got other issues you want to?
No, I think the only sort of message for me alongside that is that there are an awful lot of factors that will impact on our ability to continue to deliver any of our ambition within set timeframes. So agility and flexibility is going to be the watchword for the next 12 months, I think.
And hopefully no COVID.
Hopefully no COVID.
No hands up. So Matt, I think you're next.
Thanks, Chair. So obviously the financial plan that we've developed is based around the strategic intentions that set out in the IMTP, but more specifically the operational and planning assumptions particularly, because obviously they drive the financial planning from both an income and expenditure point of view. So I'm hoping you'll be familiar with the way we constructed the plan from our previous engagements and also through committee structures, that we set out the plan split between our core underlying position in terms of pre-COVID. Then we had the COVID element in terms of the COVID costs and assumptions around income. And then finally, the national extraordinary cost pressures that have started to face this last financial year and going into the next. So if you remember, in terms of the earlier iterations, we were still setting out a balanced financial plan at that point, but with fairly significant risk assumptions around income, on COVID funding, particularly around the response costs, and then also in terms of the extraordinary cost pressures. So then on the 14th of March, we had a letter from the Director General for Health and Social Services setting out the Welsh Government's aim to underwrite the risk, the financial risk around the COVID response costs and also the extraordinary cost pressures. So clearly, in terms of our plan, we updated the financial narrative to reflect that, and clearly that dialed down some of that risk fairly significantly, because there was a chunk of cost there that we were making assumptions around income, and we now have cover. So just be clear though, they are still saying in Welsh Government they don't have a pot of money sitting there. They're saying they are managing that risk on behalf of Wales centrally. So we are allowed to put a plan in that assumes income cover for that, those costs. So obviously everyone's touched on the demand modelling and therefore the sort of capacity required, and that's a fundamental aspect of the financial plan that we've done. And we have done risk analysis around that in terms of sensitivity. At the moment, based on the modelling we've done around our new contracting model income, which is what our commissioners agreed, over and above the baseline 1920 levels, we would use to generate additional funds, which links to the new funds flow mechanism as well that has been agreed nationally. And that's something else that's only been signed off literally in the past week. So you can imagine the financial plan has moved quite a lot, and it's quite difficult, with deadlines to get papers into board. So I'm trying to articulate to you the things that have moved more recently. So that funds flow mechanism plus our contracting model, when you model through the demand that we've basically worked very hard with health boards on at an operational level, as Kath said, it gives us income cover at the marginal income rate, with that funds flow protection model covering our baseline COVID recovery costs. But as I said, downside and upside risk we've modelled. So where supposedly demand was down by 2%, for example, or up by 2%, we've done that modelling as well. So what Steve, though, is also doing with the chief execs of the health boards is having a strategic conversation around the downside risk on that. So say the activity doesn't come through based on what we've modelled, we can't be in a position as a trust, and I know you know this because it's in the narrative of the MTP, holding the baby fully in terms of the recovery costs that we've already implemented, i.e. the capacity we've put in place. And the final thing we're in, no, exactly, because that would be, well, it would be silly. We know how difficult it is to recruit staff. They know that. We've transitioned staff from COVID response, some of them as well into recovery, and we wouldn't be looking to remove those staff, but we do need that additional discussion. Having said that, I'm pretty fairly confident around the demand modelling, though, in the sense of even with some of the sensitivity analysis, we would still be able to cover that base cost probably 2% below what we've modelled. So we've got some element of cover and assurance, but it'd be nice to have that, sign up with the chief execs as a strategic approach, saying, let's not be in the situation of worrying about that downside risk. We've got the capacity there for you. We've paid, sort of put it in place, paid for it, and to have that sort of strategic agreement would be great. The only final point then is...
Matt, what you don't want is we don't want to be into boom bust, do we? No. So that, you've got extra demand coming down because we're in a post-COVID and then something happens and it reduces. We don't want to, we need to have a very level, with appropriate contingencies for marginal costs and so on. But we want to avoid a boom bust cycle.
Exactly, but we also need the flexibility for the upside example where demand goes beyond what we've got in place. Yeah. And part of that is we know at the moment the internal capacity we put in place probably only covers circa 90% of that forecast demand. And there's another 10% that we need to go outsourcing to rubber in particular. And the problem with that is, as you know, is a premium cost to that. And that's the bit we need to agree, because the funds flow mechanism is something I've been flagging for months. Does not, the national one now, does not take an account of outsourcing premium costs. So it assumes you can live with the funding that would come through the LTA mechanism. And that would be fine. It pays for part of it, but it pays for a small part. And if I give you an example, you potentially got the 4 million cost for that 10% of outsourcing when you're paying a premium. It would cost £1 million if we could put that capacity in place internally. So we are challenging ourselves to do as much as we can internally, and Kath described all the things that we're doing. But at this point, we will still need to use outsourcing, and that's where we're at with further dialogue with our commissioners around that. So hopefully that gives you the story of how it's moved in the past 2 weeks since the various committee discussions and the previous briefings. But overall, balanced position with risks, but a lot less risk than 2 weeks ago. 3 weeks ago.
So thanks, Matt. I've got Gareth, Andrew. Gareth and Andrew, please. Gareth first.
Thank you, Chair. I'm glad to hear that the position around volume and writing costs appears to be getting a bit clearer now. But just historically, just to give some more assurance regarding that downsizing of volume and requirements, and ignoring COVID, have we undershot the volumes over the last few years, or have we come in there or done more than we've been asked?
Yeah, so in terms of the last 2 years, which is why we've benefited from the All Wales block contract arrangement, we were under our 1920 baseline, which is the pre-COVID, and all organisations were running at lower levels. As you'd expect, patients weren't coming through the system because of the COVID risk. But as Kath, I think, and others have described throughout this board meeting, that activity has massively picked up this year in a number of our key services, not least SACT, which is actually beyond the 1920 levels, and beyond our previous normal growth levels, which is reflecting some of the COVID, I suppose, but not backlog, but patients that would have been coming through earlier are now coming through as a bulge on top of our normal growth. So, and radiotherapy, even Kath was saying in January and February that started to pick up and is now at our 1920 levels. So that's why I suppose in terms of the modelling we've done and the demand that we're predicting, I've got more confidence that we can actually cover off that base cost now. But it is, as we talked about earlier, about the assumptions, they are only as good as, the day you make them. And that's why we have weekly, monthly discussions with the health boards, because they are fundamental in all this, aren't they? Because we have to know what they're doing around their diagnostic capacity, what they're doing around their endoscopy capacity, what's happening with their surgical cases, and when they're getting their act together in capacity affects our modelling massively, clearly. So.
Yeah, thanks. Really interesting discussion, and I'm fully supportive of the IMTP. Just a reminder, really. I mean, we are a university trust, and that brings great benefit. Thinking about increased future demand, increased future workforce planning, and all of those things. Wherever we can cultivate those links with the universities, and make those research and innovation links, set up the educational programs, all these things linked together, and make ourselves visible to the Cardiff University, where I work, at training hundreds and hundreds of medics, nurses, pharmacists, etc. So we, in a sense, we're in a good position, because where we can build those good links with our local universities, those are the places where the specialist staff of the future are coming from, if you like. And that, we know that many people who, let's say, come to Cardiff to do their medical degree, you know, even if they're not originally from Cardiff, they often stay in the area, and you know, and we should continue to work to make Velindre very visible to that population, because that's just going to help us. I think whichever way we look at this, we're facing increased demand for services. We're facing potential issues with access to specialists, particularly specialist clinical staff. And so, yeah, I think we're in it's a positive message, but just to continue to develop those links. And we're doing that, so that's good.
And I know that's happening also for nursing, allied health professionals and clinical scientists as well, Nicola, isn't it? Yeah. So I'm looking around the room. Nobody has their hand up at the moment. So, oh, Steve, you want to come in?
Not on the specific, I was just going to do a bit of...
You doing a mop-up? Yeah. Well, before you do that, Steve, could I just... God, this is chaired by negotiation, isn't it? So before you do that, we have looked at this plan in its development over several months and in several committees. I want to just ask the board, is everybody content that issues and concerns and comments that they've made and raised have been taken on board by the team? Is anybody left with any residual concerns? Because we do want to try and get this off today if we can, Carl, don't we? So, Martin?
Quite the opposite to concur. We were given the opportunity to comment offline, and those comments have gone in, and Phil Hodgson is responding that he's collected all of those things, and they're mostly tidying up. Invoice doesn't exist anymore, that kind of stuff, and that's all happened. That's not reflected in this document, but just to say those things have been mopped up behind the scenes.
Yeah, everything that I sent to Phil has been incorporated. I'm pleased to say. So, Gareth,
and just to reiterate Martin's point that subject to the assurance we've had from Phil Hodgson, that our points and comments which we've had in have been taken on board.
Yeah.
We have an opportunity to agree a final version with those commitments made.
So, Steve, I'm handing over to you for
I've certainly seen an email from Phil this morning saying he's got all those. And not taken into the document, so yeah, they have been built in. And the only other change is picking up Matt's point about some changes around what's happened in between and the financials might tweak those. Underlying plan is broadly the same, so it doesn't change the plan. It changes some of the layout and some of the wording around income flows. But it's as Matt described, so it's not different from the description we've had.
So,
just to say, just a couple of points from me here. I think does that help? Just a couple of things. Clearly, we've discussed today and through the process, this is a plan which has got significant operational and financial risks in it, probably more, I'd say, than this organisation's had in the years I've been here. But we're clear about those. We know what they are. We need to manage them. We need to engage with partners and government about doing that as well. So I think that's an important place to get to and understand that it's not a risk-free plan. We've been used to being in a slightly different place, I think, in this organisation, but it reflects where everybody is. I think if you talk to any of the organisations and the plans at the moment, what's helped over the last month has been some of the things from government about support for pressures, but it is not a risk-free plan. And I think, again, it's part of the reason I want to stick really close to what's happening in you and bring it back to the board and QSP on a regular basis. So we're absolutely clear about where we are, because we are in a different place than the one we've been used to being in.
Thank you. I'll get that right just by the end of the day. I'll have the rhythm right. We are asked to approve the IMTP 22 to 25 for submission to Welsh Government on the 31st of March 2022. Could I, by show of hands, please ask the board to approve this IMTP? I've got some subsidiary notes I want to make, but first of all, to approve it. I think that's unanimous for the minutes. And I just also want us to note the next steps and actions, which is we will submit the plan later today. And then when we receive feedback, we'll respond to any of the feedback that we get from Welsh Government. And I've no doubt that we will get feedback which will require response to us, and we'll take that on board. We are going to develop an easy read version of between 3 to 5 pages, which Carl has just said would probably come in about early May. That we'll have that, and that we continue to work with our key partners and stakeholders to support the implementation of our IMTP for 2022-25 and the successful delivery of the key actions and the priorities that we've identified, and that there will be reporting of progress against the implementation of the key actions which are in this plan in line with existing governance arrangements. So those are the kind of next steps. So I just want to say this is a very significant, very important piece of work. It's taken a lot of work, and I'm very pleased to note that the board has arrived at this position where we are all fully in support of submitting this IMTP to Welsh Government. Congratulations to all my colleagues for their part in getting it to this place. So now we come to existing IMTPs, item 8.2.0, which is the Q3 update on the existing IMTP. And I'm thinking that Kath's going to lead this, but you might have had a conversation about that. So Kath, I'm going to hand over to yourself.
Okay, got it. Sorry, I got a sticky hand now. I wasn't intending to go through them individually. I'm just happy to take questions. I think it's of note that not all of these are operational. They're actually the action plans for the corporate services as well. So it is slightly wider than just me in the hotspot. But just to say that yet again in this current year, we have managed to deliver a phenomenal amount against our plans, which with our somewhat naivety with retrospect, we made this time last year, not recognising that we still have quite such a COVID burden through this financial year. So I'm just happy to take any questions, as long as you bear with me while I flick through the pages of it on my sticky iPad. Chair, you're on mute again.
Oh, gosh. Does anybody have any comments or queries for Kath on the Q3 report of the IMTP?
Stephen.
Oh, Stephen Harris. Yes, I couldn't make out that your hand was up, but I have now. So, Stephen, the floor is yours.
It's just a quick question, really, out of interest for myself, in terms of one of the activities in the it's the Annex 1 document. It's the gathering patient feedback on the use of virtual appointments, which sounds very interesting. I just wanted to check with you, Kath, presumably that's feedback from the patients and, as you said earlier, carers and families, because obviously the virtual appointment situation has an impact on not just the patient, but also the families and the carers, either positively or sometimes negatively. So just some assurance around that.
Yeah, the detail of exactly how we went about that, I'm going to have to find out for you, so I'll come back to you. But I am aware of the fact that the piece of work was being done, and actually it fits as part of a wider discussion with across Wales in terms of the use of virtual appointments that is an ongoing one we're having with Welsh Government. And we're really mindful in that. The comments that that Stephen Allen brought to us when we first started implementing them, and we're really getting used to them, around what patients do have virtual appointments and what patients don't have virtual appointments. At one stage it was necessary to do as many as possible, and that potential connotation that if you were coming in person versus having a virtual one, that it was bad news. There were so many aspects of this that we really needed to investigate further. So if it's okay with you, I'll provide you with an update on that piece of work outside the meeting, but I'll copy it to the whole board.
And presumably, Kath, once that work is completed, there'll be learning for us, which we can pass on to the to staff as we go forward, because we can't assume, that it just dropped on us from above that we all were 100% proficient in virtual consultations from day one. We've had to learn how we do that, and so any feedback we receive will go straight back into learning how best to take that forward.
Yeah.
So Martin, Vicky, and then Stephen Allen. I'm not sure if that's the order in which your hands went up, but bear with me. So Martin.
I'll take it. Thank you. Just in terms of the presentation of this, I mean, it's very helpful to get this detailed analysis of where we are. Actually, at the end of February, most of the details are, so it's pretty much getting towards year end now. Just understanding, we haven't actually explained what green, amber and red actually means in this context. And actually, I take it just by comparison, the two appendices are quite different in their layout and what they actually mean. So, for example, in the Velindre Cancer Centre document, there's a delivery appropriate capacity to meet patient demand. It says slipped and will be delayed until 22-23, and that's marked as amber. In the Welsh Blood Service, things that are slipped into 22-23 are marked as red. And I'm just just a note for future reference, really be consistent about what we mean by red, amber and green. Is it a close miss or is it a complete miss? And just the presentation would be helpful to actually understand a little bit better.
That's helpful, Martin, but of course slippage in one service is not as serious as slippage in another, so that's why it's helpful to
so understand what the colours mean. That's right.
Yeah,
which is why we need to have a conversation about that, really, what is important.
Carl, were you going to come in there?
I think I've remembered turning on as well, so I'm learning, which is good. No, I mean, I think the point's well made. Just in terms of the process itself, Martin, amber means we're still on target to deliver. So I think green is we're delivering and red is we ain't. But we need to go back around that because there's variations, you say. So we'll pick that up and A, add the key, this and B, then make sure that we're applying that consistently.
And some say done, and some close, and some don't, and it's like
So yeah, we'll sort that for you as you've described.
I think just to reflect the discussion we had in QSP, because we looked at Q3 in terms of the PMF, and we were saying that actually Q3 was originally due January. We were reviewing that in March, and we're pretty near, obviously, on the last day of March now. So it's actually, it just reinforces the point about the year-to-date performance, so that we're not caught out in terms of, all of the understandable reasons for that late reporting, but actually, therefore, your risk of failing those targets for the end of year were very real, given the time that we were looking at it. So again, that ties in with, so your TAF as well.
Issue, but not necessarily on a performance issue.
Well, I think the performance.
It's not reported.
Yeah, I think the performance issues that were being reported for the end of Q3, we were looking at in March, and we were saying, therefore, what's the material difference between what was stated for the end of Q3 to actually the delivery by the end of Q4, which normally you'd report on in terms of April, or indeed going into May.
So point well made. Val, I can hear you. Do you want to come back?
Yeah, no, it's a really important point. I guess there's two things: the reality and lag time. But I think the management information for that purpose, and then there's what we report to the committee for assurance. Yeah. We are trying to get that as tight as is possible. As we all know, there will be a lag, but I think your point's really well made. Here we get it as good as it can be, and then try and reduce any lag so that you get a chance to. So we are working on that, and it's always going to be slightly not where we want it, but the management information is far more routinely and timely than perhaps the committee stuff is able to, because as you know, it goes through a series of steps before it gets to. But I think that's something else we might want to look at is what's good enough, I guess. But yeah, we'll take that away.
So you have that undertaking, Vicky. Stephen?
I just want to pick up on the digital issue that Kath was talking about, and again, some of the learning you can learn. There was a national report that was produced by the CHCs across Wales based on the feedback we have from the public on accessing digital appointments and digital technologies in order to engage with the NHS. Whether or not, I don't know whether you've actually seen that report, Kath and the board, but we can actually share that with you, which actually may give you some pointers in what people have been saying about using digital things from the start of the pandemic right the way through to where we are now.
Stephen, I hadn't seen that. I'd really, really welcome it. But we've actually got a meeting with Welsh Government on Monday, which often provides us an opportunity for discussing this sort of thing. So if there's any chance we could have it before Monday, and I can give it a read before Monday, it would be useful for the discussion with Welsh Government colleagues that are leading on the digital enablement piece.
I think they've already seen the report, but yes, I'll send that to you over shortly.
And it's also important, you know, that we're getting the feedback from our staff, which I know we are, because some time ago we had 2 clinical nurse specialists and they each described 2 very different experiences of working virtually. This was quite early on in the process. I'd be interested to know what the feelings are like now that we are 18 months down the line from when we had that presentation from 2 of our CNSs. It would be interesting to know, because it's important. We need to know that our patients are comfortable, but we need to make sure that our staff also are comfortable in that virtual space. Stephen, thank you for that comment. If you could get that report to Kath, make her better prepared for the meeting next week with Welsh Government. And so we note we'll note the points that have been raised in discussion, and we'll receive and note the progress against the IMTP 21-22 Q3 update. We're coming to the end of the agenda for this Part A meeting. So before I move on to any other business, and I haven't been informed that there is any, I'm just offering colleagues, if anybody feels, you know, at this stage in the meeting, they wish they had said something about any one of the items before we close the meeting. I always do this on reflection. You know, does anybody feel that, you know, that we didn't allow them to have the discussions that they wanted, or I cut them short or anything? You can speak up now and we'll see how we can address the concerns. Gareth, I can see your hand up. I'm so nervous now.
Just for the record.
Write it down. Write it down. No, I think it's always important. I don't want anybody to walk out of the room thinking, "I wish I'd said whatever." And if it's not said here, it's invisible to the public. That's the important point. So, that being the case, I'm looking at the screen. There's no hands up there. That being the case. Thank you. I know any other business that's been brought to my attention before the meeting. We had a bit of a shaky start, and it's taken us a while to get used to the microphones and so on. But on the whole, I think that this has worked, and it has been so positive and productive to see people and to have some chats with people, for those of us who've been present today. In person, as it were, and we'll thank in due course the staff of the Holiday Inn for their support with the technology. As I say, it was a bit of a shaky start, but I think we've got there, and we're about to finish 10 minutes ahead. So now I come to the last item on the board, which is to adopt the following resolution: that representatives of the press and other members of the public be excluded from the remainder of this meeting, having regard to the confidential nature of the business to be transacted, publicity on which would be prejudicial to the public interest, in accordance with section 1(2) Public Bodies Admissions to Meetings Act 1960, paragraph 67. The date and time of our next meeting is the 26th of May at 10 a.m. I'm looking to you, Lauren. Do we presume it will be in a similar format?
Yeah.
So it'll be in a similar format. Colleagues, let us know if you're wanting to attend in person or not, so we make the appropriate arrangements. And with that, I conclude this part A of Velindre University NHS Trust board meeting for March 2022.